All right, so chapter 7, the human body. We are moving right along with this. Let me just minimize that and get it out of the way. It'll be good to start. All right, so obviously, looking at the fundamental knowledges that we have, safety, well-being, EMT, med legal, all that kind of stuff, ethical provisions, emergency care. And looking at AEMT, we're going to go more in depth on this stuff here and go through these educational standards and competencies. I do appreciate the text messages that I'm getting, though. All right. I'm guessing that Mike is listening as well. So, all right. I will do the best I can, Mike, to teach you something that you do not know. We'll try my best. All right. We apparently have people listening. I'm guessing he's in Waterboro tonight. All right. So gross anatomy includes body parts visible to the naked eye, right? So things that we can see. That's what we're going to be looking for. And we'll go more in depth on the assessments here shortly. But the microscopic anatomy that involves components of the body that are small, often visible through a microscope. This is the important stuff, right? Because this is where medications start working. These are where things start happening, right? And this is what we're looking for. Understanding how these medications work within the system, looking at the pharmacology and how it works, makes your job better. It makes you a better clinician because then you have an understanding of, well, the protocol says give this. Okay, well, what does it do? I don't know, right? Well, now you need to know what it is. You need to know what you're looking for and what the actions, or I should say, a mechanism of action is going to be. And this will help you with your treatments and what to expect. So if you give, for example, if you give somebody a sympathomimetic medication, you expect to see things that mimic the sympathetic nervous system causing increased heart rate, things like that you would see with that. Or if you give somebody an alpha medication, you're going to expect to see some dilation, something with a vasculature change. It might be an alpha 1 or alpha 2. Or if you see something with the beta side of things, like a beta 1, we're going to get that stuff here in pharmacology and a little bit in the human body, is, looking at beta 1 being something that's rate control, right? Or beta 2, something that works with bronchodilation in the lungs. So there's a lot of things that we're going to look at in the physiology examine of body functions. And this is where all this kind of stuff plays into this, right? So physiology examines the body functions of the living organism, what's currently there. And moving into the advanced level, and once you get higher into the different levels, whether you're paramedic, critical care, it gets more in depth and how this stuff actually works. So let's go over some basic stuff first. The basic functional unit of the body, the cell, is extremely varied in the shape and function. So the cells, they mature or differentiate and become specialized to perform a specific function. We'll get more into those functions later on in the presentation. So cells with a common function are grouped closely together and are called tissues. We know what those are, right? A bunch of cells together creating a tissue. These groups of tissues that all perform interrelated jobs form organs, right? So a series of organs working together make up the body system, right? So how many body systems do we have? See eyes moving, people thinking. Any ideas how many body systems we actually have? Take a guess. Someone jump in.
7 off the
Keep
top of
going
my
up
head.
a little bit higher, right? There's 11
8?
different systems. 11. Yeah, it's okay. 11 different systems within the body, right? So all these cells perform excretion and respiration. So how do we remove that waste product, right? Whether we use the lymphatic system, whether we use respiration, things like that. And then we also look at cellular signaling, which were cells, they actually communicate through the electrochemically within themselves and externally. So we're going to kind of go more into that as well. So this is more of the cell structure here, and I'll try to do some drawings, horrible drawings that I can do, and we'll draw on here as long as my connection continues to work right. So we have the cell structure itself, and there's some important things we need to know about within the cell structure. But there are two general classes of cells. There's sex cells and somatic cells. All right. And then the second part is the nucleus contains a genetic material and controls all activities of the cell itself. So who remembers anything about biology? Anybody? A little bit, right? Some of the important stuff. So the mitochondria, what is that?
It's the powerhouse of the cell.
The power. Yeah, you remember that. Remember, it was the powerhouse of the cell, right? And then we have lysomes right here. So we know this is the powerhouse. The lysome is what? It's kind of like the destruction cell, part of the cell, right? So the way I think of lysomes and the fire service is like a truck company going in and doing total destruction with ventilation and everything else, right? And we have the powerhouse, right? The mitochondria. What about the nucleus? What about here? Kind of like the one in charge, right? The center of attention, like the incident commander of a fire scene, right? Trying to throw some different things at you guys. You can kind of remember certain things of this, right? All right. So what about this right here? Why would this be important?
It's what feeds the cells.
Right. And glycogen being something like, what does it help convert? Glucose, sugar, right? So we look at that as well. So to kind of make a kind of a point with this here as well, there are three things that a body needs to survive. What are they? So like the fire triangle, take one away, the fire goes out. Move one of these, the body dies. Yeah, I know it's a tetrahedron for those firefighters in the room. I get it, but I'm going back old school. All right. So what are the three things it needs to survive?
I know oxygen and sugar.
Sugar, right?
Water.
O2. And you say water, we'll just do this instead. Blood. If you cannot give patients sugar, blood, or O2, the patient will die. Okay. Eventually they will die. They will go into shock and they will die. Right. That's why it's so important to have understanding how these cellular structures work, because if things aren't working appropriately, then at that point in time, the body can't oxygenate. We can't produce the sugars that we need. And we can't, if we don't have any blood, we become hypovolemic. With low blood volume, what can we not transport? Oxygen, right? So we'll get into that here in a moment. So the cell membrane, also called the plasma membrane as well, molecules that form pathways that allow movement into and out of the cell, right? So you can see the different layers that are here. The pathways allow signals from the outside of the cell to be detected and transmitted inside, looking at the cell and how that works. It's extremely thin and delicate, and the tiny folds on the surface help increase surface area, right? So you can see the inside here, the hypophobic layer, so the inside of the cells. Then we have the interior down here. This is the exterior part of the cell out here. This is the kind of the barrier in between, going between the exterior and interior part of the cell. So these are composed of a bilayer, which containing phosphate and fat molecules called phospholipids. So anything that ends in lipid is a fat molecule. Keep that in mind as well. So they are also semi-permeable. Cytoplasm is a fluid-like material in which the contents of the cell are contained, right? So cytosol is a fluid portion of the cytoplasm. The fluid I think the next slide has a picture of it as well. It may. It's hard to see. It's pretty small on my screen. We'll go to the next slide here in a second. So this contains mostly water as well as glucose, amino acids, fatty acids, ion lipids. What else is in there? Proteins, adenosine triphosphate. Another name for that would be ATP. Right. So do not forget about ATP. That's very important for the transition and waste products. So many of the chemical reactions necessary for life take place within the cytoplasm. All right, so organelles accomplish tasks related to the cell structure, growth and maintenance, and also metabolism. Let's see if it's in here. All right, so organelles have specific actions that help the cell carry out an activity, right? And these are the four things, and I'll kind of describe both all these four that are up here. The first one is called the centrioles. So the centrioles, oh, I lost my screen again. During cell division, centrioles form the spindle-shaped structure needed for movement of DNA, right? The cell division then requires a pair of centrioles. The cilia and flagella extend from certain cell surfaces. So cilia moves fluid over the surface of tissues, while the flagella propel the cells to the right. These formed it's the endoticulum paths how proteins move. So there's two types. There's a smooth, which lacks ribosomes, and then there's a rough, which has them. Okay, those are the two differences with that. So the Golgi apparatus deals with proteins synthesized on ribosomes itself. There are three main functions: is concentrated secretions that are released for secretion of the cell. Two, enzymes inside vesicles used for cortisol or cytosol. Sorry, not cortisol, cytosol. And then the other one is renewing and modifying the cell membrane. Right. That's the complex, the Golgi apparatus, the three things within that. Lysomes dispose of the cell waste using enzymes to break down nutrients and foreign particles. All right. Microfilaments are composed of the proteins actin and myosin, which provide cell movement and contraction via the interaction with actin and myosin together. That helps with that movement and the contraction. The mitochondria, which we talked about, Jen, the powerhouse of the cell. All right. Did I lose you guys at all? I don't see movement on camera, so I don't know if I lost you or not.
It was going in and out for me for a little bit, but it kind of came back through.
All right. Is it back now?
It is now, yeah.
Okay. I apologize for that. Like I said, the internet's pretty spotty, so I'll have better internet starting next week. Right. So excuse me, the mitochondria are the powerhouse of the cells, which have double membranes that play a central role in the production of energy. So the outer mitochondrial membrane is smooth, while the inner mitochondrial membrane has a series of folds as well inside. Thanks, Mike. All right. Yeah, I keep losing my connection on my computer for some reason. It's not working the greatest. All right, so the nucleus, the largest structure in the cell, this serves as the control center. This is like your EOC. This is like the emergency operations center. This is your home base. This is the person in charge, right? This is the largest structure there. This contains the genetic instructions needed to synthesize and the proteins that determine, cell structures and functions. The structures consist of DNA and other various proteins. So inside the nucleus is a fluid called nucleoplasm that suspends the nucleus in the chromatin, right? All clear as mud, right? Everybody shaking their head, yeah? Okay. This is the basics. When we get into pharmacology, a lot of this stuff will make sense as we bring this back around. Then you can have an idea of how it's working within the system. This is just kind of the basics of how the cell works. All right. So life cycle of the cell, how the life cycle works, regulated via stimulation from hormones or growth factors. So most human cells divide between 40 to 60 times before they die. Right. The life cycle of a cell has 4 different phases, right? 1, the interphase. Then you have mitosis, which is cell division. Then you have cytoplasmic division, or what they call cytokinesis, and the other one would be differentiation. So let's break these down a little bit more. The interphase. The interphase is the period of preparation to divide. So as it's getting ready to, it's prepping to divide itself. So the cell manufactures new living material and replicates its own genetic material after that. So the cell division and the cytoplasmic division. Lost my connection again. And we're back. The mitosis and cytokinesis are two types of cell divisions. Meiosis reduces the number of chromosomes by 1/2, okay, which occurs in production of eggs and sperm. The mitosis is a cell duplicates itself into the daughter cells, right? So identical copies. The cytoplasmic division, or the cytokinesis, begins during the second phase of mitosis. All right, you guys got that so far? I know it's a lot. Your best bet is to reread this again in the book. Kind of go more over it again as well. Let's keep reviewing this part of the cell. So the cell membrane consists down the middle portion of the cell and divides into cytoplasm. So the two newly formed nuclei are then separated, and half of the organelles are distributed into each new cell. All right, so that's how that works. The differentiation is the process of specialization of a cell, which makes the cell unique. So a stem cell can divide repeatedly without specializing. This can divide into identical daughter cells, or divide so that one daughter cell becomes partially specialized, right? Which we call a progenitor cell. All right. So cell division in cancer. One second, I'm gonna reply back here. So kind of make a mention to this too as we're going through these presentations. If anybody from the fire department's like listening in on this and they want to partake and jump in, I'm more than happy to give Con Ed hours for the National Registry. So I just make a certificate of completion after you're done, as long as you can show that you're participating in the class. I don't mind doing that for some people. That's fine. All right. So I apologize. So the cell division and growth occur approximately at the same rate as cell death, right? That's why we're rejuvenating. Things are going around and around. Neoplasm, or the mass of tissue produced by an abnormal cell growth and division. That's a neoplasm. The benign tumor is more of our cancer stuff. The benign tumor, when it remains within the epithelium, cell that becomes life threatening can usually be surgically removed. That's your benign. But your malignant tumors, those are the ones that cause spreading. Okay. So understand the difference between both of those. You're going to see those again as we move forward, right? Benign versus malignant. Malignant tumors spread into surrounding tissues. I'm sorry about that. I was reading the message from Mike too at the same time. Malignant tumors spread into surrounding tissues in a process called invasion. So with this may result in a malignant cell traveling to other organs, okay, or tissues to establish secondary tumors. That people call it METs, cancer with METs. That's called metastasis. So when it starts metastasizing to other parts of the body. All right, so malignancy occurs when a normal gene mutates, when the cancer cells then change shape as they grow and gradually resemble normal cells less and less. All right, so presence of a tumor cell then stimulates the growth of new blood vessels. As metastasis increases, organ functions start to change. All right, so cellular respiration. All right, so why would this be important? I'm sure all of you did your reading before the class.
Cells create their own waste too, so it needs to be exchanged as well. Kind of like lungs breathing in and out.
Exactly, cellular respiration. And this can change by how we oxygenate and everything else. We're going to talk about the citric acid cycle, well, formerly known as the Krebs cycle, here in a moment. Right. I'm not going to go in depth because even paramedics hate the Krebs cycle. Right. It can become a pain to learn, but there's a lot behind it. Right. So cells use glucose, right, and oxygen to release energy from organic compounds. Imagine that, sugar and oxygen, two of the three things the body needs to stay alive. Okay. So that's why we mentioned those three things. Glucose requires three types of reactions. One is glycolysis. Two is the Krebs cycle, or otherwise known as the citric acid cycle. And the third one is the electron transport chain. So those are the three types of reactions that have to happen. With that, a result of cellular respiration is carbon dioxide. So how do we measure that? How can we look at carbon dioxide in the field?
The end title.
The end title CO2 monitoring. How can we monitor oxygenation?
SpO2.
SpO2, right? As long as we have good pleth, that's the important part, right? And this is my little tangent on these two here. They work hand in hand, but one is not really better than the other, except for the fact that we can see second to second monitoring with end tidal CO2. We can see if a patient is perfusing, right? If you look at oxygenation with a pulse oximeter, even though you have good pleth and good waveform, it could take minutes to start seeing a difference in pulse oximetry readings. Okay. And we don't have the ability to get true blood gases in the back of the ambulance through an ABG or a BBG, so we can't see that. What we're going to see is a change in respiration. All right. So that's why it's so important to understand how end tidal works and look at the numbers, whether it be alkalotic or acidotic, and then the true numbers behind it. We'll cover that here in a moment. Right. So we see carbon dioxide. We can monitor that with end tidal CO2 monitoring. The other part is water. Water, blood. We have to have that for cellular respiration, water, movement. And we also have something called a high energy molecule, which would be ATP or adenosine triphosphate. So glycolysis occurs in the cytosol and the cytoplasm, which involves a series of enzymatically catalyzed reactions, right? In which glucose is then broken down to yield lactic acid and pyruvic acid. This does not require oxygen, all right, to form there's a form of anaerobic metabolism. Does not require the oxygen there. If oxygen is present in the right amounts, pyruvic acid can enter, can enter the more energy efficient pathways of aerobic respiration. Aerobic reactions yield as many as 36 ATP molecules, right, per glucose molecule. 36. So this figure here shows anaerobic metabolism versus aerobic metabolism during the process of anaerobic metabolism, which occurs in the cytoplasm, right? The breakdown of glucose results in lactic acid. So during aerobic metabolism, which occurs in the mitochondria, the breakdown of glucose results in carbon dioxide, water, and adenosine triphosphate. Well, 1 second. My apologies. I have to answer the phones for this week. Next week it goes to the other supervisor that's on. I don't have to be the manager on duty next week. All right. So as you can see, the cellular respiration here versus aerobic versus anaerobic metabolism. So if you look at the differences here, so it kind of breaks it down. All right, so the Krebs cycle, otherwise known as the citric acid cycle. is a form of aerobic metabolism. So the sequence of enzymatic reactions involve the metabolism of carbon chains of glucose, fatty acids, and amino acids. This occurs in the presence of oxygen. All right. So when food is ingested, large macromolecules are broken down into simple molecules. With this, the proteins are then broken down into amino acids. Carbohydrates are broken down into simple sugars, glucose. Fats are broken down into both glycol and fatty acids. Excuse me. Glycerol and amino acids are then broken down into pyruvic acid. Okay. So after glycolysis and the Krebs cycles have occurred, a total of 4 molecules of ATP have now been produced. When oxygen is absent, respirations can still occur via an anaerobic process. Okay. This stuff will all make sense to you when we start getting more in depth into the lactic acid stuff. But lactic acidosis can develop with shock due to, therefore, our muscles, right, are breaking down. We start seeing the elevated in lactic acid. Now, I mentioned lactic acid. What's the first thing that comes to mind for you? What's the first thing that comes to mind when I say lactic acid is elevated?
Muscle cramps.
Muscle cramps. Okay. So some kind of muscle injury of some sort. Crush injuries can have an increase in lactic acid, also increase in potassium as well. We'll talk about that later on in trauma. Right? What else though? Can a patient have an increased lactic acid if they're septic? Yes. Right? We look at numbers now, right? Lactic acid number in a lab value should be 0. Should be 0. We should not have any in there at all. Should be no lactic acid. If you have a lactic acid of 30, would you think the patient's septic? Feel free to unmute because I can only see one camera at a time trying to watch everything here until I get my bigger computer screens. If you had a lactic acid of 30, would you consider the patient to be septic? So the correct answer is no. This is why. Okay. You're not going to see elevated levels of lactic acid, 30s, 20s, in patients that are septic because we have that muscle breakdown, right? Normally what you'll see is a lactic acid of 2, 3, 4, sometimes 7 or 8 lower numbers. Those are going to be more your septic patients, but it's not just looking at the lactic acid number. There has to be other things behind it in order for a patient to become septic. That causes that widespread vasodilation, bacteremia, and all that other stuff that goes along with it, which we'll cover in medical emergencies and shock. But bringing that up, the time talking about lactic acid, though, is you'll see those higher numbers in injuries. Okay. So crush injuries, build up of lactic acid, right? That's truly a paramedic call with a crush injury because there's medications they can administer to help neutralize and also push potassium in and out of the cells. And we have medications that can do that. Okay. So what we're looking for here is understand that lactic acidosis can develop with shock. We got to figure out what type of shock is actually causing that. So electron transport chain, there are 34 molecules of ATP that are produced in an aerobic process, right? Overall, the process is termed aerobic respiration. So for cellular respiration, glucose and oxygen are required. Nearly 1/2 of the energy is recaptured as high energy electrons stored in the cells through synthesis of ATP, adenosine triphosphate. The end result is 38 molecules of ATP, right? So electric transport chain has 34 molecules, and we talked about earlier, and bring it back here a little bit. There's 4 additional ones that are broken down and made through the Krebs cycle after glycolysis. Okay, so you have the 4 from glycolysis plus the 34 from the electric transport chain, which are produced in aerobic process, an aerobic process, let me get that right, which totals at the end 38 molecules of ATP. Right, you're probably going to see that again on one of your tests coming up. Okay, Krebs cycle 4, 34 for the aerobic process. Okay, that equals a total of 38. So cellular transport mechanisms. So cellular transport mechanisms refer to how materials enter and exit the cell. So the cell membrane is selectively permeable, which helps maintain homeostasis, that even ground of the body, how we live. All right, electrolytes are chemicals that are dissolved in the blood and are made up of salt and acid substances. Interesting, right? What do we carry on the ambulance that has electrolytes in it that you could administer as an advanced EMT?
Lactate ringer.
Yeah, LR. All right. So here's my little soapbox on this. I have to make this presentation about it. We carry 2 different types of fluids on the ambulance that we normally administer. What are they? One's ringers.
Saline.
One's
Normal
is normal saline. All right. Now our body, we have to run it, and now we're going a little ahead, but you guys probably already know this. What is the normal pH level for the human body? We're going to be covering this in this chapter, but we're going a little ahead. It can run from 0 to 14, 7 being neutral. Where does our body run? Do we run acidotic, neutral, or alkalotic? The 33.33% chance you're going to get it right.
acidotic.
Right? Go the other direction.
Go.
Yeah, we run on the alkalotic side. Now,
Yeah.
right. And you're going to need to know this for acid-base balance. And this is also part of what we're talking about with the human body, right? Our body, our normal pH is 7.35 to 7.45. Now, absolute normal is 7.4. If you're looking at, as a respiratory therapist, they look at absolutes. Absolute is 7.4. Now, we look at it in the EMS world, 7.35 to 7.45. So you're probably like, what is this even talking about with ringers, right? Why is he bringing this up? Normal saline that we carry, sodium chloride, is not so normal, right? The pH for normal saline is 5.5, where ringers is 6.4. Which one is better for the body?
One that's closer to how we run already.
Right. Yeah, that's a pretty good answer, right? So the 6.4. But there's a time and place to give saline, there's a time and place to give ringers. Okay. Sepsis, ringers all the way. Trauma, ringers. Right? Blood follows ringers better than it does following saline. Okay. That's why when you're if you ever work in an emergency department or whatever, they'll usually hang ringers before they go to surgery, not saline. Now, should we just be dumping ringers in every patient we come in contact with? Depends. Depends on the patient and the presentation. 95-year-old female patient, dehydrated, should we be dumping a ton of ringers into this patient? Probably not. That'd probably be a bad thing, right? Because remember, there's potassium, sodium, calcium, all these different electrolytes built into lactated ringers, right? So that's a good question that was just asked to me as well. So try to think how to answer this question appropriately here. And that's a very good question as well. Does LR more or less likely to third space. So third space, you mean interstitial fluid building up. Okay. So we got to remember, how does third spacing actually happen, right? Especially for patients with hypotension. It would depend on why they're hypovolemic. That'd be the first thing I would want to find out is, do we need to treat it with hypovolemia with a blood loss? Then I would be going with ringers to establish that. If they're hypovolemic based on vomiting and diarrhea, ringers might be a better option. But what is causing that hypovolemia? And whether or not we want to give a patient too much sodium, because remember, sodium does pull water from the cells, right? And it takes it and probably cause more third spacing. I have seen in my experiences, I can say, I cannot speak for everybody else, that I've seen more third spacing based on saline than I have ringers, right? Because there's more sodium, it's at a higher sodium content within the normal saline bags that we do carry. Right. There are other medications that are out there for the paramedics, and not right now. I think Massachusetts has it, but I don't think New Hampshire or Maine do at this point in time. And I haven't been in Maine in a little while, so if I'm wrong, Mike, feel free to correct me. But I don't think we carry hypertonic saline at this point in time in Maine. That'd be more of a paramedic thing.
We don't currently have anything other than LR or normal saline.
Okay.
But usually for me, for personal, and I'm sure as for you as well, my go-to is usually lactated ringers because of all of the benefits that you're going to get
Correct.
from your LR over your normal saline.
Absolutely, 100%. So there are a lot of benefits, and people that tell me normal saline is normal, it's got a lower pH, which is actually really not good for the body. So use the way to kind of answer the question is use your clinical judgment of how you want it to administer, and what is your overall goal to complete treating this patient. All right. So electrolytes are chemicals that dissolve in the blood that are made up of the salts or acid substances that are there, which allows differences in concentrations between intracellular and extracellular environments. All right. So the difference in concentrations of a substance on either side of the cell membrane is called the concentration gradient. So each cell membrane then determines whether materials are allowed to pass through. Right. So this is all going to be based upon what we're going to be administering. So diffusion is a passive movement of a solute moving from one area of higher concentration to an area of lower concentration until an even distribution of particles have been achieved. All right. So as you can see on the outside of the cell, so this is the inside of the cell, outside of the cell, this is that membrane down the middle here. This is simple diffusion, right? Lipid molecules or soluble molecules are passing through until this side equals this side. So we have the same amount of little molecules to equal both. That's simple diffusion, right? So this is that movement back and forth, right? And then this is more of the gas, right? The gas moving back and forth. We'll talk about the fluid or the osmosis shift here in a couple of slides, right? But we want to make sure that with simple diffusion that the higher of greater concentrations, I'll put a G here, greater concentration has to go to the area of lesser concentration through the gradient until both sides are equal. All right, that's simple diffusion. Filtration is another method of moving substances. So what filters? The kidneys. The kidneys filter compounds from the blood, and waste are removed through the blood and excreted into the urine. All right, and we'll break that stuff down in a little bit here and how the kidneys work. Okay, and then we'll talk about different medications that patients can take to help stimulate certain loops within that kidney, inside the nephron, inside the kidney. Facilitated diffusion is a carrier molecule that moves substances in or out of the cells from high areas of high concentration to areas of lower concentration, where energy is not required. The number of molecules transported is directly proportional to the amount of concentration there. So active transport is the movement of a substance against a concentration or gradient, right? So endocytosis or exocytosis are the processes that use energy from the cell to move substances into or out of the cell without crossing the cell membrane, right? There are three forms of endocytosis. Okay. The first one is pinocytosis. The second one is phagocytosis. And the third is receptor mediated endocytosis. Those are the three forms that are there. So if you look at this figure here for facilitated diffusion, right, this shows the particles. So A, looking at A, the particles move from an area of higher concentration to an area of lower concentration with the assistance of a protein. All right. B shows the active transport, which uses energy from adenosine triphosphate, ATP, to open the pathway for compounds to move against a concentration gradient. Right? So as you can see, B, looking at ATP down here, oh, that wasn't low enough, there we go. Right? Using that as a binding site to help transport the iodine ions through the cell membrane to meet that diffusion. That's facilitated. It's being assisted by ATP to pull that through. Okay. If that's not available, then you have other transport proteins to help pull the pull the molecule through the cell. That way there goes inside and meets that diffusion state, right? To make sure they're equal on both sides. Does that make sense? There's two ways of pulling it through. These are facilitated diffusions, whether it be a transport protein or ATP as an assist as well. Did I lose anybody on that? Maybe a little bit. Everybody okay? Thumbs up, thumbs down. Good. All right. Speak up. Remember, if you guys need a little more explanation, to speak up and I can try my best to kind of explain it better for you. So osmosis is a passive movement of a solvent or liquid from an area of lower solute to a one of higher concentration through a selective permeable membrane. Membrane is permeable to the solvent, but not the solute. So osmotic pressure, which measures the tendency of water to move by osmosis across a membrane, right? So as you can see the sodium ions here. So where would this be important within the body? We're moving sodium, potassium, calcium. What will we see there? Why is this important? Moving these cells. How about the heart, the pump, right? Electrical conduction system, right? We have to have these. Remember, these are all formed of electricity. So sodium potassium pump within the heart itself helps move in and out. And we'll talk about that here when we get into cardiac emergencies. I just don't want to deliver too much at once with this. So tonicity, as you can see here, is the concentration of a solution or its ability to draw or give water. So a solution with a higher solute concentration compared with another solution is called hypertonic. So I was just talking with Mike a few minutes ago about the hypertonic saline, which has a higher solution, higher solute at 3%. Our normal saline that we're administering currently is 0.9%. Right? We usually use that more for head trauma, but there are other things that are out there as well, different fluids that help retain more in the body as a hypertonic fluid. So a solution with a lower solute concentration is called a hypotonic. What we're administering is what they call isotonic solutions. An isotonic solution is one where there is an equal concentration of solutes and liquid on either side of the membrane, right? And that's what we're utilizing. All right, so crenation, if too much water moves out of a cell, then the cell shrinks automatically, right? You start seeing that collapsed cell for the hypertonic versus hypertonic. I'm going to show you guys here in the pictures that you're seeing. Lysis is too much water enters a cell, it will swell and burst. Okay. So you see the hypertonic, isotonic, the normal cell. So the isotonic would be your LR normal saline. Okay. That's what we're seeing here. If we have hypotonic solution and we give too much, we can actually have cell bursts. If we're seeing giving too much hypertonic solution or fluid, right? The cell walls can collapse, turning into this here, right? That water movement out, which is why we utilize more hypertonic solutions for head trauma, head injuries. We start seeing that, right? But for us at the advanced EMT level, we're giving isotonic solutions, which will keep the cells normal and help move. Now, keep in mind that LR and saline, as great as they can be, they're not whole blood. All right. You start talking about hypovolemia in patients from traumatic injuries as well. So having the ability to administer whole blood or calling for, DART, Life Flight of Maine, getting them on board, calling for ground units, whatever that carry whole blood products or FFP, things like that, or PRBCs, then that's when they're going to start giving, that gives you the ability to help transport that oxygen where fluids do not. We can actually over fluid somebody in a patient who is in a traumatic injury or bleeding out by turning their blood, like let's like to call it turning it into Kool-Aid, because we don't have that ability to provide platelets and blood cells, RBCs, red blood cells, to transport that oxygen. That's why it's so important to have the difference between them. So yes, we can give this can happen. We can administer LR or saline, but they need to get to definitive care if it's a bleed. Now, in a patient who's hypovolemic from vomiting or fluid loss from diarrhea, things like that, LR is probably one of the better medications, and I agree with what Mike was saying as well before. This is his fluid of choice because the electrolytes behind it and how close it is to being a normal pH. And everything that we do has to be based on that acid-base balance of medications that we're administering to keep that homeostasis. Does that make sense? Yes, no, clear as mud, perfect. All right. So we talked about the body fluid balance. Right now we're starting to get into the organ systems and things like that. Once my screen comes back, perfect. All right, so, and after this, we'll take a break. All right, so the body fluids are divided into two main compartments, intracellular and extracellular fluid. Intracellular fluid, or what they call ICF, exists in individual cells and equals approximately 40 to 45% of the total body weights. Extracellular fluid, or ECF, exists outside the cell membranes and equals approximately 15 to 20% of the total body weight. So ECF is divided into intravascular fluid and interstitial fluid, right? That's that interstitial that between the layers that we were talking about a little while ago, that third spacing. Intravascular fluid or plasma is found within the blood vessels and accounts for approximately 4.5% of total body weight. Interstitial fluid is located in the spaces between the body cells and accounts for approximately 10.5% of the total body weight. If fluid is lost from anywhere in the body, it disturbs the balance among various fluid compartments. So fluid balance maintains homeostasis through equal intake and output of fluids. So the major mechanisms for homeostasis are listed in your book, so you can take a look at those tables. I don't have them on my screen here. But the sensation of thirst occurs when the body fluids become decreased. So the body can maintain fluid balance by shifting water from one compartment to another. So let me ask you this now. Now we're getting into shifting of fluids. What if there is too much? Where does it go? Where can it go?
Interstitial space.
Interstitial space, right? So if your heart is not pumping effectively, and let's say the right side of our heart is failing, where will we see fluid buildup?
Is this where you get your pitting edema?
Exactly, right? +1 to +4 pitting edema, right? Because now our right side of the heart is failing, causing it to back up into the vasculature of the extremity. Now, if the left side of the heart is failing, where would the fluid then back up to? It's got to go somewhere.
That goes to the lungs, right?
Right, and we start seeing acute pulmonary edema, right? So our body has to balance effectively. Now, if a patient is meeting homeostasis and we decide, okay, well, we can just dump a liter of fluid into a patient, could that harm them? Austin, maybe not you so much because you can help homeostasis, you can help produce that or maintain that fluid, but do that same thing to a 100-pound 95-year-old female, then we're going to start seeing different things happening. One, maybe fluid buildup in the lungs, or interstitial spacing of fluids. So this is why anytime we're giving somebody any kind of fluid management, we talk about that bolus, and we're going to talk about modified Parkland formula for burns, and we're going to talk all about this stuff here later on down the road in this class. This is why every 500 mLs of fluid you give to a patient, you check lung sounds, right? Fluid is great until it can no longer take it anymore. Then it's got to go somewhere else. 500 mLs lung sound assessment, 500 mLs lung sound assessment. And we will talk about the true bolus of fluid versus an IV drip or a wide open drip, right? Because there is a difference in how we administer it, and a lot of things can change if done the right way. We'll get into that here in a little bit, right? So looking at the diagram that we have, right, as you can see, working its way down from the increased blood sodium concentration, right, the osmoreceptors in the hypothalamus, moving down the pituitary gland, and we look at the antidiuretic hormone, or ADH, right? This helps start stimulating the antidiuretic hormones, start stimulating. We're starting to push fluid out now, goes through the bloodstream into the kidneys. The kidneys are then going to excrete that waste water product through the urine byproducts and increase water reabsorption. Goes back around in the cycle. So as you can see, it starts up here, works its way down, and then increased water reabsorption comes back up again, and the fluid chain continues, right? This is how we meet that homeostasis. So if we have any changes, let's say a patient in kidney failure, okay, and they can no longer push out fluid, is this a patient that I want to give 3 or 4 liters of fluid to in the back of the ambulance? No, because they can't excrete it. The fluid's going to have to go somewhere else, right? So these are things you want to ask the patient. Do you have any kidney issues? And we start getting more into some lab stuff later on, we can talk about that. But we got to look for patients that have kidney problems, right? So one thing you can ask about that may have kidney issues to help stimulating a removal of fluids is what medication can a patient take that can help excrete fluid, help move that fluid shift. Another name for what we call is called a loop diuretic. I'm sure all of you have heard this before once I say it.
Good old Lasix.
Good old Lasix, furosemide, right? Loop diuretic, but the one thing about that, and this is something important for you guys to know about pharmacology, I know you can't administer it, but something to pick up on. It's a loop diuretic, but it's also a non-potassium sparing diuretic, which means it will deplete your potassium. Okay? And if you deplete your potassium, what can happen? Especially if somebody overdoses on it.
Cardiac
We're not talking
arrest.
about the EKG changes as well. Okay. And we're not going to get into how those look. This is not a 12-week class, but cardiac changes definitely though. Okay. But you'll definitely see some stuff there. So we got to look for that potassium. Right. So a lot of things happen with medications that people are taking. That's why it's so important to have an understanding of pharmacology and how that works. So if we have a loop diuretic, which is stimulating the ascending and descending loop inside of a nephron, pushing out the fluid, not keeping potassium within your system, can cause cardiac changes. Okay, so it all leads into something else. That's why it's so important to make sure we meet that homeostasis and everything functioning appropriately. All right. So I should have said 12. My apologies earlier, Jen. It's 12 major systems on 11. So an organ is composed of at least 2 kinds of tissue that are organized to perform a complex task. There are 12 major organ systems in the body. All right. This is important for you guys to know because patients that have sepsis or severe sepsis septic shock can have multiple organ dysfunction, MODS. And having an understanding how these different organs work will give you an idea of where things are going. There are 12 major organs within the system. I'll cover those really quick, read them down, and then we're going to take a break. So the first one is the integumentary system, so the skin. Skeletal, muscular, nervous, endocrine, circulatory, lymphatic, immune, respiratory, digestive, urinary, and reproductive. All right, we're going to start hitting all those here when we come back in 10 minutes. All right, I'll see you guys in 10. Everybody back? Let's see, who are we missing here? All right, so we got 1, 2, 3, 4, 5, 6.
I'm
All right,
back.
so how are we doing so far? Doing okay? Questions? Good for right now? A lot to take in. All right. Hold on tight. We got a lot more to go. All right. Let's talk about the skeletal system. Everybody can see my screen okay? Perfect. All right, so the skeletal system anatomy. Okay, a lot of this stuff we're going to see right now is going to be review with some additions to AEMT. So the skeletal system anatomy the skeletal system gives us a recognizable human form and protects our vital internal organs. So, excuse me, the bones constitute the major structure of the skeletal system. We have cartilage, we have tendons, ligaments. All these parts are really important connective tissues. All right. So if you look at in your books, if you have the books 7.-3, this will be a lot of your support structures in the skeletal system are listed here. Remember that a tendon connects muscle to bone, where a ligament connects bone to bone. A sprain occurs when the bone ends partially or temporarily dislocate, and the supporting ligaments are then stretched or torn. A strain or a muscle pull occurs when a muscle is stretched or torn, and cartilage provides a cushion between the bones. So we're going to get more into this stuff here. That's kind of the down and dirty, quick anatomy of that. So classified according to their shape as long bones, short bones, or flat bones. So long bones would be your femur, your tibia, your fibula, ulna, radius, humerus. Right? Your short bones, wrists, and ankle bones. And your flat bones are certain skull bones, ribs, sternum, scapula. Irregular bones have unique shapes and are also designed to perform a specific function, which include the mandible, many of the facial bones, and those that comprise of the vertebrae within the spine and pelvis. The long bones consist of a shaft called the diaphysis, which ends the shaft, the diaphysis, and the ends, the epiphysis, and the growth of the epithelial plate, the growth, or otherwise known as the growth plate. So the physis. The growth plate is the major site of bone elongation. Okay. Looking at the pictures here. All right. So the growth plate being down here. Why is that important for us to know? Pediatric fractures, right? So pediatric assessment, pediatric fractures, make sure that we're stabilizing and splinting appropriately. Okay. So the periosteum consists of a double layer of connective tissue and lies in the outer surface of the bone. And the endosteum lines in the inner surface. The diaphysis of many bones include the medullary cavity and also the internal cavity that contains bone marrow. There are two major types of bone. So two main types of bone that compact bone and the compact bone and the calcaneus bone. Not calcaneus. Oh my God, I can't even think today. Having a moment. The cancellous bone. So the compact bone is mostly solid with a few spaces. I think the calcaneus is on the heel. I don't know why I said that. I was just reading it wrong. And the cancellous bone consists of lacy network of bony rods called tuberculae. So I'm trying to see if there's something on here. It's right on the right bone to be utilizing. Right. Trying to give a better picture on here because you guys are going to be doing IOs. I'm just going to kind of go into IO or osseous access, but it does go into the bone marrow itself. I'll find a better picture to show you. once my screen comes back. All right, so joints are whenever two long bones come in contact, so a joint articulation is formed. All right. So a joint consists of the ends of the bones that make up the joint and the surrounding connecting and supporting tissue. Some joints have slight limited motion in which the bone ends are held together by fibrous tissue called a symphysis. So the important things to pick up on in here. Your knee, let's see if I can draw this here. What kind of joint is this?
Hinge joint.
Yeah, hinge joint. Perfect. Right. Things to pay attention to. So where the bones come together and come into contact. So you can see the femur comes in, connected by a ligament, right? This is the fibula out back here, tibia being up front, the patellar tendon, the quadricep tendon, things like that. We look at the joint spaces. When we start doing assessments, looking at the patellar tendon, things like that, we start doing assessments on the leg itself. What we're going to do is, if we're checking like a patellar tendon tear, if the knee is bent, what you want to do is you want to take your two thumbs, encapsulate the knee, go below the patella, and kind of push up with your two thumbs, like an upward motion. All right, and that'll help you tell if it's a patellar injury, a patellar type tear of the patellar tendon. Other things too, the patella being here can dislocate. I've seen a lot of times it will either drop down, or I see most of them either dropping down or dropping to the side. All right, as far as patellar dislocations, or excuse me. All right, the quadricep muscles, very important for us. These are where a lot of some IM injections go into as well. Looking at the quadricep muscles, moving up into the quads, which will probably obviously extend up here. Right. We'll get more in detail here in a second. So the bone ends of the joint are held together by a fibrous sac called the joint capsule. So on the inner lining of the joint capsule is a synovial membrane. Okay. Inside that synovial membrane is something called synovial fluid, right, which is a thick lubricant that helps keep it, I'll say, lubricated. So the shoulder joint is a ball and socket joint. And the next picture here will actually help out a little bit better. Then the finger joints, elbow, and knee are hinge joints. We get into the hand, I'll show you some other joints that are also located in there as well. All right, so the axial skeleton is divided into the axial skeleton and the appendicular skeleton. All right, these are the two major portions. The axial skeleton is composed of the skull, the thoracic cage, and the vertebral column. All right, so we have here the thoracic cage, here, and the column going straight down. All right. Then our appendicular skeleton is both the arms, legs, and their connection points and the pelvis. So as you can see, where all the bones connect in. So we have our ball and socket joints here, right? Our hinge joints located down here. Ball and sockets are here. All right. Down here will be more of your hinge joints. And then you have your other joints in the hands and wrists, and we'll cover all those here in a moment. The heart and lungs and the great vessels are enclosed in the thorax, or what they call the thoracic cavity. There are 206 bones in the skeleton that provide a framework for the attachment of muscles. The only time you'll have more than 206 bones if you have something called a Wormian bone, which not everybody has. And those are in the ear. Sometimes people have them, and sometimes they don't. So the skull consists of 28 bones in 3 anatomic groups. The auditory ossicles, the cranium, and the face. The 6 auditory ossicles function in hearing, and the remaining 22 bones comprise of the cranium and the face. The mastoid process is a cone-shaped section of a bone. Okay. So we have, and you guys see the little squiggly lines through here, like that. Those are called sutures coming through. All right. We have our frontal bone here, frontal, temporal, parietal, occipital. All right. So as you learn the bones, they're also the same lobes underneath them. Parietal lobe, temporal lobe, frontal lobe, occipital lobe. And every one of those lobes has a different function within that. So like, for example, if somebody hits the back of their head and hits the occipital lobe, right, that controls the vision field. The orbit, located right here, okay, or the eye socket, is a bone that can easily fracture. And one of the assessments that we're going to do with that is we're going to put pressure with our thumb and go around the eye socket and see if they have any pain. All right, you're also going to pick up on some raccoon eyes as well. All right, and we have our basilar skull, which sits back here behind the ears, probably the better location here. All right, and if we have bruising back there, that would be called what again? What is that called? We have a basilar skull fracture. Start seeing something called bruising behind the ears is the name for it. Anybody? You guys still hear me?
Battle signs.
Battle signs. Perfect. All right. Now, if we have bruising around the orbits, what is that called? These are than our,
Raccoon eyes.
yeah, raccoon eyes, exactly. All right. Then we look at our face and the facial bones here. We have the mandible, maxilla, the zygoma or zygomatic bone. Our nasal bone here. Remember, the nasal bone is short, and the rest of it's filled up with cartilage around it. And then our eye or our socket. So we have the cervical vertebrae, right? So we have the vertebrae starting up here, 1, 2, 3, 4, 5, 6, and 7, right? What these are called C7, C6, C5, C4, C3. What is C2 and C1 called? There's a different name for those. So C1,
Is it axis in the mantle or something?
Atlas.
Atlas,
Yep.
that's what it is. An axis.
think of the globe, the atlas, sitting on the axis that spins, right? Not exorcism spinning, but it spins. All right. So we have the cranium here and our different bones within the head, right? Perfect. All right, let's go to the next one. The cranial vault consists of 8 bones that encase and protect the brain. The parietal, the temporal, frontal, occipital, sphenoid, and ethmoid bones. The brain and the spinal cord are then connected through a large opening called the foramen magnum. That's the big hole. I'll show you guys that in the next slide. All right. The bones of the skull are connected together at special joints known as sutures. The fibrinous tissues called fontanelles link the sutures together. So let's go a couple things here. Right. We have the coronal suture, kind of like the coronal plane that we talked about in last class, right? Then we have the metopic suture here, right? We have the sagittal suture, like the sagittal plane we talked about before. We have the coronal suture that goes straight across, right? We have the lambdoid suture, which is out back. And then we have the anterior and posterior fontanelle, right? Why are these important? Mostly this one here.
Pediatrics.
Pediatrics. And what specifically in pediatrics will that indicate? And I'll give you that. I'll give you more to that as well. If it's bulging, what would that indicate?
Cranial pressure.
Right? Intracranial pressure. If it's sunken,
Dehydration.
yeah. I'll just do DEHYD. That's an E, I promise. All right, it's for dehydration. Now, do we take our thumb and start pushing on that? No, but can we push on it lightly to kind of feel? Absolutely. And this should be part of your assessment on pediatrics, is feeling for that anterior fontanelle. So if you're documenting this connection again, if you're documenting in your narrative, you're going to document that you assess the anterior fontanelle, not the posterior, but the anterior fontanelle. All right. You're not going to have much back on the posterior, and that usually connects a lot faster, but we'll have the opening of the anterior fontanelle for a while in the pediatric. All right. So that's one of the things you want to make sure you're doing some assessments on. All right. So the floor of the interior of the skull, the cranial vault, is divided into 3 compartments: the anterior fossa, the middle fossa, and the posterior fossa. All right. Here's that foramen magnum that I was talking about here. Okay. There's 3 different sections. The crista galli forms a prominent bony ridge in the center of the anterior fossa, and on either side of the crista galli is the cribriform plate and the ethmoid bone. So the olfactory nerve, okay, one of the 12 cranial nerves that we have, sends projections through the foramina and in the cribriform plate and into the nasal cavity. Right? You guys can see the different bones within inside. The plates, the sphenoid bone being here, the optic foramen, temporal bone, occipital bone, frontal bone, right, working our way right around. The carotid canals, you can see where the carotid arteries go. The carotid canals are here. The jugular foramen, the foramen magnum being the big hole here. All right, next slide. All right, so the facial bones. So the frontal and ethmoid bones are part of both the cranial vault and the face. There are 14 facial bones that form the structure of the face, include the maxillae, the mandible, the zygoma, which used to be the zygomatic bone, palatine, nasal, lacrimal, vomer, inferior nasal concha bones as well. So, and then the facial bones protect the eyes, nose, and tongue. So I'm going to mention a bone here really quick. All right. And this would be some significance to something different, but the lacrimal bone. But get rid of the word bone. Let's say the lacrimal ducts. What are those?
Tear ducts.
Ear ducts. So why is that important? And stand by 1 minute. I got to answer that really quick. Come up with why that would be important if you see increased. All right, sorry about that. I'm back. All right. So one of the things, what would be significant of a patient is something that would be BLS, but to recognize, but significant of lacrimation.
Like if nerve gases, like sludge them.
Yeah, organophosphates. Perfect. I know it's kind of off topic, but I brought that up, and it's good to throw different things at you guys as we're going through it all. All right. So those are the 14 facial bones, including the facial bones that protect the eyes, nose, and tongue. Muted myself again. There we go. All right, the bones of the orbit. So the bones of the orbit are the cone-shaped fossa that encloses and protects each eye. This contains blood vessels, nerves, and fat as well. So a blow to the eye may result in a fracture of the floor of the orbit. So remember I mentioned before that the raccoon eyes, you start seeing that with that. It's a very brittle bone around the eye, the socket itself, the orbit. So it can actually fracture fairly easy. So a blowout fracture can cause leakage of blood and fat into the maxillary sinuses. So going into here. So the nasal cavity comprises of portions of several of the facial bones. The nasal septum is the separation between the nostrils and the paranasal sinuses. All right. So the nasal septum and the separation between the nostrils is located in the midline, right? So located in the midline here being the separation of the two. All right, this contains cavities known as the paranasal sinuses, and sinusitis is an inflammation of the paranasal sinuses. So anything that ends in itis being an inflammation. The mandible and the temporomandibular joint. All right, so the mandible is a large movable bone comprising of the lower jaw and containing the lower teeth. The posterior condyle of the mandible articulates with the temporal bone at the temporomandibular joint, which is called TMJ, allowing for movement of the mandible. The hyoid bone supports the tongue, and it is the only bone in the body that is not connected to another bone. And it sits in the superior aspect of the neck. So looking at the neck here, you can see the different cartilages and the different muscles. So the neck is supported by the cervical spine. So the upper part of the esophagus and the trachea lie in the midline of the neck, right? So you can see the trachea here working its way down, the white part down here as it goes down in, okay? The carotid arteries are found on either side of the trachea. So you can see the red arteries here, carotid arteries. And there are several useful landmarks that can be placed or palpated and seen in the neck. One being the Adam's apple, or the upper part of the thyroid cartilage, and the lower portion is called the cricoid cartilage. Between the thyroid cartilage and the cricoid cartilage, in the middle of the neck is a soft depression. This is what we call the cricothyroid membrane. So for medics, this is a pretty important landmark because this is where surgical crics or quick trachs or things like that are going to be performed, right? The sternocleidomastoid muscle originates from the mastoid process of the cranium and insert into the medial border of each collarbone and the sternum, the breastbone at the base of the neck. Right? This gives the neck a lot of the ability to move and provides a lot of strength in the neck, the sternocleidomastoid muscle. Right? The blue parts that you're seeing here are your jugular veins. And there's an internal and external jugular. Also an important landmark if you're doing what they call an external jugular vein or catheter. Right? This is more for the paramedic level, but that's where they would access that. Right? And you can see, and you can actually palpate, and you can feel in any one of you, if you pick your head up and start feeling your neck, you can actually palpate that cricothyroid membrane located right there. So the central supporting structure of the body is the spinal column. Remember, there are 33 vertebrae, 7, 12, 5, 5, and 4. Okay. So the central part is we have the cervical spine, the first 7, C1 through C7. The thoracic spine is the next 12 vertebrae going down, T1 through T12. The thoracic spine, the lumbar spine, the next 5 vertebrae from the lumbar spine down. And then you have the sacrum, which is comprised of 5 fused vertebrae, and the coccyx, which are the last 3 to 5 vertebrae towards the bottom. Okay, normally it is 4. Those are also fused as well. All right. So there's something else called dermatomes. You guys heard of dermatomes before? That's a body sensory. There's 2 dermatomes you should remember, and the rest of it will all fall into place. The first one is T4, and the second one is T10. All right. T4 is nipple line, T10 is umbilical line. And from there, you can pretty much figure out everything else from there. As long as you know where T4 and T10 are located, you can understand dermatomes and how things work, right? As far as pain, right? Perfect. So as far as the spinal column goes, the cervical, my goodness, the first cervical vertebrae C1 is called the atlas. So the atlas articulates with the occipital condyles at the base of the skull at the atlanto-occipital joint. The second cervical vertebrae, C2, known as the axis, is the point at which the head rotates. So think of it as something being plopped on top and it can spin side to side, up and down, okay? That's your access point. The spinal cord is an extension of the brain, so contained within a protected by the vertebrae of the spinal column. So the interior part of each vertebrae consists of a round, solid block of bone called the body. Right. So the vertebrae are connected by ligaments, and between each vertebrae is a cushion called the intervertebral disc. So have you ever heard anybody say, I have a slip disc? That disc is when it starts sliding out. So the spinous process, okay, right here. When we're doing our spinal assessment and we're palpating from C3 down, because you really can't feel 1 and 2 because they're kind of buried up inside the foramen magnum as it sits, right? So you start palpating down. We're feeling that spinous process, okay, to see if it's been chipped off or if it's deviated in any way, shape, or form, right? So we talk about step offs and things like that as well. We're looking for the body to kind of slide one direction or the other, or if we have any crepitus of a broken spinous process. So now in your documentation, as you're palpating, you're documenting your narrative, spinal cord assessed with no step offs or spinous or crepitus noted. Not just did a spinal assessment. Okay, what did you do? What kind of assessment did you do? Right. Now you can see the nerve roots located here and over here. Here's your spinal cord being protected. The nerve roots allowing to transmit signals through the body. And you can kind of see where C1 through C7 goes down here. These 3 here, 3, 4, and 5, keep the body alive. Remember that, okay? Your respiratory center, everything is all run through here. All right, if this severs in the spinal cord in this area here, your ability to be able to breathe goes away. Okay. That's why it's so important to place cervical collars on patients, to make sure that that is the best possible ability to make sure that that does not sever that spinal cord there. All right. The thorax is formed by 12 thoracic vertebrae, and there are 12 pairs of ribs. So the boundaries of the thorax are the rib cage, anteriorly, superiorly, and posteriorly, and also in the diaphragm inferiorly. In the anterior midline of the chest is the sternum. Okay. So as you can see that the ribs are connected from the spine out back and come around and connect into cartilage, as you can see here. All right, so it comes around and you have floating ribs down below. This is all cartilage on both sides. Okay, we have our sternal notch. This is our sternum located here. That little bony structure down here is a xiphoid process. If you've been around EMS for a while, that used to be a landmark for CPR back in the day. Now they just go lower half of the breastbone. Right, these are all your costal arches located here. All right. As we're doing our assessment of the thorax, we want to make sure that we start at the clavicle, and then just below that starts rib number 1. We want to make sure we palpate every single rib going down, feeling for any kind of crepitus or flail segment, so 2 or more broken ribs in that area. Okay, and do a good lung sound assessment on these patients as well. The upper section of the sternum is called the mambrium. All right. The body comprises the rest of the sternum except for a narrow cartilaginous tip inferiorly, which is called the xiphoid process, which is located at the bottom. The largest structure within the thoracic cage are the heart, lungs, and the great vessels. Just beneath the mambrium is the sternum, the arch of the aorta, and the pulmonary artery exit the heart. So the esophagus lies behind the great vessels and directly on the anterior aspect of the spinal column. So all space within the chest that is not occupied by the heart, great vessels, and esophagus is occupied by the lungs. All right. And it's kind of hard to see here, but you can see the great vessels. This, I'm trying to draw it over the red here, right? Your aorta comes up like this and wraps back around again. Okay, you have the great vessels off the top. So literally it'll look something like this. You'll have, we'll say this is the heart, right? We'll draw the aorta coming up. It wraps around. So ascending aorta, aortic arch, descending aorta. Of course, I lose connection as I'm drawing. Stand by a second. Okay, we'll come back. You have your great vessels that come off the top of the aorta, the aortic arch. As it comes down, it'll branch off. That's horrible. Right? These here are called your renal arteries, and it continues on down and branches off into your femoral arteries going down into the legs. All right. So these go to the kidneys. These are your renal arteries here. Your great vessels up here going into the brain, subclavian artery, things like that. They're all located up here, and your heart being here in your 4 chambers. Any questions on that at all? That's kind of behind the picture that you really can't see. I'm not the best artist, I can tell you that by any means, not the best, but I can kind of explain to you how that kind of works. All right. So we have the heart, right atrium, right ventricle, left atrium, left ventricle. Inside there are 4 valves, right? So TPMA. I always tell people it's called toilet paper my ass. Way to remember it. Right? Tricuspid, pulmonic, mitral, aortic. Those are the 4 valves in order. Right? We have our pulmonary artery and pulmonary veins coming through here. Remember that pulmonary arteries are deoxygenated blood, which means that the right side of the heart is deoxygenated blood coming through. Okay. Now, everybody heard of pulmonary embolus before? PE. So a PE will sit somewhere up in these vessels. Okay. Now, there's a way I can. Second here. I'm going to draw this out for you. I'm going to erase all this now. Erase. All right. So, ever heard of a saddle PE before? You ever heard that term before? Saddle PE. That's a pretty bad PE. That's where the PE, I'm going to draw it in red, sits here and kind of saddles over both vessels on both sides. That's a massive blood clot. Okay. I've had patients with this before, and I've seen this on the CTs. It's pretty interesting to see them. And take a look at it on Google too. You can Google image it, look at saddle PE, and you can kind of see what they look like. The massive blood clot that can actually cause a patient to die almost instantly. I've had patients with this before that have had these, that had to go through surgery and have them removed. But that's where a PE would sit. Okay. So we have our deoxygenated blood coming in, picks up oxygen within the lungs and circulates back through, right? So it starts in the right atrium, the right ventricle, into the lungs, through the pulmonary vein, through the pulmonary arteries, to pulmonary vein, back into the left atrium, to the left ventricle, into the aorta through the ascending and descending arch, so coming up and around through the renal arteries down into the femoral through the body. That's how we're going to oxygenate. That's how we're going to transport blood. All right. So any questions with that part so far? Did I explain it a little bit better for you and how that works? All right. Good. All right. So the largest structures within the thoracic cage are the heart, lungs, and the great vessels. So just beneath the membrane of the sternum and the arch of the aorta, or the pulmonary arteries exit the heart. The esophagus lies behind that, remember, okay? And the esophagus is occupied by the lungs, so you can see the large mass of the lungs that are here. So it kind of hides everything behind it. All right, so the appendicular skeleton. This includes the bones of the shoulder and pelvic girdles, right? So the upper extremities and lower extremities. The shoulder girdle attaches to the upper extremity of the body at the glenohumeral joint. And the two major components of the shoulder girdle are the scapula and the clavicle. The clavicle right here is a very, very commonly fractured bone, okay? It's under a lot of tension, there's not a lot of support, and we get a lot of clavicle fractures. The raised tip of the scapula is called the acromion process of the scapula back, the raised tip. And if I can see, there it is. Okay. So right here, the raised tip there, the acromion process. The shoulder joint, which is a ball and socket joint, in which the head of the humerus articulates with the glenoid fossa, which is part of the scapula. A bursa is a pad-like sac situated between a tendon and a bone that cushions and protects the joint itself. All right, so the upper extremity consists of the arm, forearm, wrist, hand, and fingers. We'll get into the fingers and hand here in a second. The humerus is the bone of the upper arm. So humerus, you have the bicep, triceps back here, the lateral condyle, medial condyle, think lateral, medial, inside, outside, the O'Clerian process, going down into the ulna and radius, ulna being underneath part, the radius being on top. Think of the radial artery. You check a radial pulse being on that side, right? Going into the wrist and into the hand. So we're going to break the hand down here in a second. All right, so the hand. The hand is broken down into quite extensively here. All right, so we have the forearm and wrist, which extends to the elbow to the wrist, which contains the bones of the radius and ulna. The radius is then located on the lateral of the forearm when the forearm is in an anatomic position. The ulna is narrow and located on the little finger side, on the pinky side. The wrist is made up of a group of 8 irregularly shaped bones called the carpals. Okay. I'm not going to have you guys memorize all 8 bones within the wrist. Just know that there's 8 bones within the wrist. All right. Structures within the carpal tunnel include the long flexor tendons to the fingers and the median nerve. The hand has metacarpal bones that form the hand, and phalanges are a series of small bones that exist in each finger. The carpo-metacarpal joint of the thumb is a saddle joint consisting of 2 saddle-shaped articulating surfaces. You only have 2 saddle joints in the entire body, and that is located here. Okay. Now we have the 8 bones in the body, or I'm sorry, the 8 bones in the wrist, right? And we have the metacarpals, right? These are labeled as metacarpal 1, 2, 3, 4, and 5. So if you're reading a report, it would say a fracture of metacarpal 1, a fracture of metacarpal 2. In the finger, the thumb has two bones, right? We have distal, medial, and proximal. Okay. So in the thumb, since there's only two bones, this one here would be distal and proximal phalanx. In the finger, you would have the distal, medial, and proximal phalanx. All right. All right. So that's how you break down the fingers. Each joint that you see here, I'm going to circle the joints. Oh, it's a little bit higher than that one there. Joint there, you can see the joints. Those are called synovial joints within the hand. So we have distal, proximal, medial phalanx, which turns into a phalange as being the finger. We have synovial joints, which are our knuckles, right? We have metacarpal 1 through 5, and we have the carpal, which are the 8 bones within the wrist. So any questions on the breakdown of the hand? Everybody good? Right. So the pelvic girdle. I'm sit here. All right, so the pelvic girdle. For the lower extremity attaches to the body, which contains a ring of bones formed by the sacrum and the coxal bones. Each coxa consists of 3 fused bones, the ilium, the ischium, and the pubis. The pelvis contains 3 joints, the 2 posterior sacroiliac joints and the anterior midline pubic symphysis. The arbitrator foramen is the opening between the ischium and the pubis that contains several important nerves and muscles, which supports the body weight and protects the internal organs. Okay. So we have the symphysis pubis. Okay. You guys ever heard of an open or a closed book fracture before in the pelvis? Okay. That's the book right there. Right. If this separates, it's an open book fracture. Right. We have the iliac crest, the ilium being the bigger part of the bone here. This is the sacrum. This is the coccyx down there. This is the pubic bone down here. All right, now you can go even more the ischial tuberosity, but then we have our femoral vein and femoral artery. Okay, remember this is the descending aorta, which is the size of a quarter in diameter with a lot of blood flow, right? In the inferior vena cava, which takes the oxygen blood back to the heart, right? So we have a major blood vessel coming down in, right? Breaks off the renal arteries, goes up to the heart, wraps around like this. Obviously smaller picture as it comes down. If you have a pelvic fracture, okay, and you sever one of the arteries because you decided that you didn't pick up on the fracture, you didn't feel for crepitus or any kind of movement, and you had an open book and it severed one of these arteries. The pelvic cavity can hold approximately 3,000 milliliters of blood. On an average adult, that's more than half your blood supply. Could a patient go into shock with this? Everybody's shaking their head, yes, absolutely. Right? Are you going to be able to see the blood leaking into the pelvis? No. How important is it to stabilize your pelvis if a patient has pelvic pain? Very important, right? Okay, so I can't stress that enough. You have a quarter size in diameter hose line that supplies your blood supply to your entire body, and you've now got a hole somewhere that's leaking into a cavity that can hold 3,000 mLs of blood on a 5-liter total blood volume in your body, averaging between 5 and 6. This is why it's so important to stabilize your pelvis. Okay. So with that being said, let's go into lower extremity. So the hip, my goodness, a lot of text messages tonight. Sorry, we had a employee got an injury tonight, so she can't make a shift. All right, let's see. So the lower extremity is made of the hip, thigh, knee, leg, ankle, foot, and toes. The acetabulum is a socket of the ball and socket joint that connects the pelvic girdle with the lower extremity. I'm going to show you guys some interesting things on this. The femur is the longest and strongest bone of the body. The uppermost portion of the femur, the femoral head, articulates with the pelvic girdle at the acetabulum. In addition to the femoral head, the proximal femur consists of the neck, the greater trochanter, and the lesser trochanter. Articular capsule is supported by 3 ligaments that are quite strong. Once my screen comes back, I will show you. All right. Patients that have pelvic fractures, okay, elderly female falls on the ground. Most of the time, I'm going to say about 80% of the time, the fracture is going to be right there. Not in the pelvic, but in the femoral head and the neck of the femur. Okay. So a lot of time for surgical repair, what they'll do is they'll come in with a small incision right here. All right. And they'll put a screw through this inside, holding that together. Right. Okay. This is where most of the fractures happen. What you're going to see, okay, if this is the leg here, well, I'm horrible at pictures, keep that in mind, okay? So here's my wonderful head, here's my body right here. Yay, he's very happy doughboy, all right? You're gonna have one leg here and one leg here. See how that one's shorter? Here's my little foot, okay? Here's my foot this way. You're gonna have shortening and outward rotation for the femoral head and femur fractures, right? So if a patient's laying down and their leg looks shorter and it's rotated outward, right? Don't go rocking it back and forth, okay? It can cause a lot of damage. Remember, there's arteries that run through all this, okay? And there's a fracture here or here somewhere, be it the femoral head or in the neck of the femur. Treatment is still going to be the same if the fracture is up top. We do not use traction splints on distal or proximal femur, only mid shaft only is the only time we ever use a traction splint. Okay, because if there is a fracture down here and you're putting the pressure down on the hip, it can cause more damage. If you have a fracture up here and you're doing traction, you can cause more damage to the knee. Okay, that's why we don't do that. So traction splinting is only mid shaft fractures. All right. I gotta make a little smiley face on him though, make him feel better. All right. So any questions on the femur itself and different types of injury? Shortening, outward rotation, neck of the femur by the greater trochanter, right? Head of the femur, lesser trochanter are the 2 different bulges here and here, right? The fracture being up here. A lot of times surgical intervention will be kind of a rod or a screw put down through here holding it together. All right. The tibia and fibula, patella, kneecap articulates with the femur, ankle joint. So let's go down through all this here. Okay. We'll talk about IO insertion here in a second. We're going to cover that again later on in the program, but I'll talk about it here with the pictures. All right. We have the pelvis, femoral head. We talked about all this stuff up here, the femur and the thigh and the hip. All right. Here's your patella that sits with ligaments, right? The patellar ligament sitting here. Here's our knee, hinge joint. Coming down into the fibula being up back, tibia being up front. Think of key for toes, toes in the front. Okay, easy way to remember it. If we're doing an IO, interosseous access, which we'll all be doing, okay, we're going to find the tibial tuberosity, which is here. Okay, we're going to go 2 fingers to the side, finding the tibial plateau, which is the flat surface here. We're going to go medial to the inside. All right, and you guys can feel on your own legs if you want to. So just below the kneecap, find the tibial tuberosity up front. You're going to slide 2 fingers medial and find that plateau, that flat surface, right? Because if you go lateral, you're not going to feel a flat surface there. It's going to be an indentation going into your skin, right? Go medial and you'll feel the bone. It's a flat surface. That is where we drill. we do a proximal IO. All right. If we're doing a distal IO, we go down here, and then the location would be, if I can get it right around this area. Okay. So we have 6 locations on the body and interosseous access can be done. We can do proximal and distal tibia and the humeral head up in the shoulder. Okay, through the ball that's up there. Right. And Laura will go over that more in detail during practical sessions. And no, we're not going to IO each other. Okay, that's not happening. Oh, darn it. All right, so the distal end of the femur and then lateral and medial condyles articulate with the proximal tibia of the knee. All right, the patella lies within the major anterior tendon of the thigh muscles and articulates with the femur. The leg is made up of the tibia and fibula, and the tibia is the longer and thicker of the 2 bones. The medial malleolus lies at the distal end of the tibia. The fibula runs behind and beside the tibia, and the enlargement of the distal end of the fibula forms the lateral wall of the ankle joint and the lateral malleolus. Right? That is the leg. Let's get into muscles. There are a lot of muscles here, tendons, ligaments. The knee, traditionally classified as a hinge joint, is the anterior cruciate ligament, which prevents abnormal anterior movement for hyperextension. Okay? These several tendons, as well as the collateral ligaments, lend additional strength to the knee joint. So when doing assessments, okay, what you're going to do to check these different ligaments for the patellar, right? We have the knee here, right? I'm going to circle the kneecap. You're going to put 2 thumbs, and you're going to put pressure right there, okay? With the knee being bent or non-bent, you can put a little bit of pressure on it and see if it has extreme pain, right? To do the anterior cruciate ligaments, when my screen decides to come back, okay? Trying to see if I can find them here in the picture. So we have the medial collateral ligament here, and we have the other ligaments on the other side. Let's see the medial there. What you're going to do is you're going to take a hand, you're going to put pressure on one side low and one side high, kind of going in each direction. That's going to cause, I'm not saying rip this patient apart, put pressure on both sides. If you have an increased pain, then we have a potential for a tendon or ligament tear on that lateral or medial side of the knee. Okay, that's how you're going to do more of that knee assessment, right? So 2 thumbs underneath, pushing up or pushing on each side. Right? Any questions on the knee at all? Knee assessment. Everybody good? All right. So the ankle. The talus articulates with the tibia and fibula to form the ankle. The fibrous capsule surrounds the ankle joint. I just want to finish this section up here and we'll take another break, okay? The fibrous capsule surrounds the ankle joint, and the metatarsals and phalanges of the foot are arranged similar to the bones in the hand. So a lot of this stuff is still going to be the same, right? I don't have another picture of this, so it's going to be hard to see, coming up. So looking at the pictures, okay, in the ankle, right, itself, right, which would be what is the ankle called? The tarsal, right? Tarsal, metatarsals. So inside the tarsal, all right, the ankle itself, there are 7 bones within the ankle. This is your calcaneus, this is your heel bone here. And then you have your metatarsals, which are your 5 bones across the top. Imagine how they are numbered. Metatarsal 1, metatarsal 2, up to 5, right? And then your phalanges are the same thing as you would find, right? Proximal and distal, right? Phalanx. And inside the knuckles, those are synovial joints, right? So any questions on that at all? All right. Trying to see where I want to stop here. All right, why don't we stop here for 10 minutes? It's actually a good place to stop, and it's 5:54. We're getting there. I'm gonna have to speed up the process a little bit faster though, because we're kind of falling behind. But we'll take 10 minutes and then we'll go a little bit faster through this stuff. We got about a minute or so left. How are we doing so far?
Doing good.
Doing good so far, you said?
Yeah. Yeah.
Awesome. 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 Love to hear it. Anybody want to work tonight? Just kidding. Might be a long drive. Uh, all right, I'll be right back and we'll get started here. Welcome back. Let's see. Mike, you look so relaxed. It needs to happen. That's it. I'm gonna go sit in the recliner. You getting much learning done? Or are you gonna fall asleep on me though? All right. So Austin, Cannon, you guys doing good so far? You were wearing like a winter hat. Are you cold?
I just like wearing hats.
That's fair. All right. I don't know what the temperature is up there. I'm not sure what it is down here though. Now I'm curious.
It is 16 here.
Oof. It's 43 right now where I am. So listen, last night it got cold. It got to 23 degrees. Okay. We need the cold weather because I'm going up to Anson, Maine next weekend. Holy crap already. Not this coming weekend, but next weekend I'll be up in Maine doing an ice rescue class. So hopefully we get some cold weather for the week and get some ice up there because I have 28 students in the class. So 28. All right, let's get back to business. We'll talk about some physiology of the skeletal system. All right. Remember, this is all in fun. All right, so bones. Let's see. I gotta minimize this though, so I can see what I'm doing here. So remember, they are responsible for several functions, right? They protect internal organs and with muscles as well, enable movement. So if someone has a fracture, that's what you mean, how you can tell. It's so important that we stabilize and we splint, right? Because they can have long-term effects with this. That's why it's so important to splint and stabilize. Right? So various bone cells use calcium to create a structure that is hard and resilient. Give me some diseases that could cause brittle bone. Give me one.
Osteoporosis.
Perfect. That's what I wanted to hear. Right? All right. So collagen fibers in bones lend like flexibility and strength to the bone as well. So it helps with the creation of various types of blood cells. Remember that in the I'm having a moment today. It's been one of those days. In the bone marrow, that's where we start. That's where blood cells are actually made up, and bones are a living substance with cells requiring a blood supply. That's why interosseous access, so interbone interosseous access, is identical to putting an IV in place. Right? You just need some pressure behind it to get to where it's supposed to go to. Right? There we go. So the musculoskeletal system, the skeletal component, form the upright posture and movement, which are provided by the musculoskeletal system. Right? The bones and voluntary muscles of the body are more than 600 muscles within the musculoskeletal system. There are 3 different types. Okay. So the muscles outside the musculoskeletal system include smooth, involuntary muscle, and cardiac muscle. Right? The skeletal. I'm waiting for it to come back. There we go. Okay. So where would you find smooth muscle? Intestines? Right? Where would you find skeletal muscle? We'll say the skeleton, right? Can these muscles rejuvenate and heal? Yeah. What about this one here, though? Can this rejuvenate and heal once the muscle and tissues are dead? No. So when we get into cardiac, we'll talk about STEMIs and things like that a little bit and then having the MI. But cardiac muscle doesn't rejuvenate, which is why people say time is muscle, right? It's important that we get oxygen back to the muscles itself within the heart. My dog is staring at me funny. I'm not sure what's going on over there. All right. So the skeletal muscle includes all the muscles attached to the skeleton, as you can see here. All right. And these some muscles within the body are things you have to be familiar with, especially when you start getting into intermuscular injections. We'll cover those here in a second. So unused muscles tend to atrophy. Okay, they tend to start dying. Whereas physical training promotes hypertrophy, not hypertrophy, but hypertrophy. Right. So most muscles within the body operate on the principle of antagonistic pairs. The example would be the biceps in the upper arm complete with the triceps. Okay, so the bicep and tricep go together. Right. This shows. So if you look at the table 7.4, which you can see here as well, locations and the functions that are there. Important ones to know. Okay, these are important ones. Right. I'm going to circle them. Deltoid. Right. Gluteus maximus. Quadricep, the thigh muscle. Right. Those are important ones to know because these are where we have potential of giving an intramuscular injection. Right. Now, I can't remember off the top of my head, and if you guys that work in Maine want to remind me, because I just don't remember. Is Toradol a thing now for advanced EMTs in Maine?
No.
Not yet. Okay. I wouldn't be surprised if it's coming down the road. Same thing with New Hampshire. I think the next rollout for New Hampshire is going to have Toradol or Ketorolac as a pain medication that can be administered at the advanced EMT level. I know it's coming. Right? Those would be administered in those. Epinephrine, that is with the advanced EMT scope of practice, right? It's EMT. Lateral aspect of the thigh, right? These are our quadriceps, so the lateral aspect. So the vastus lateralis would be the location that you'd be administering epinephrine or Toradol or whatever medication you can administer intramuscular. Okay, all your IM medications, right? This is the vastus medius or intermedius, right? And the vastus lateralis is the outside. The gastrocnemius muscle is your calf muscle. I don't know why I crossed that out. All right, then you have your pectoralis major, pectoralis minor. You have the deltoides trapezius muscles here. Why would that be important to know? Your trapezius muscles. It's a great way to elicit pain on somebody who is unresponsive. Right? Literally could walk up to any one of you and do a trapezius pinch. It most likely will drop you guys down to your knees. Right? With a little bit of pressure. And you can try it on yourself. Try pinching your traps and see the pain that it can inflict on that. I'm not saying we're trying to inflict pain on patients, but if they're unresponsive and you're using the AVPU scale, that's one of my go-tos. Right? You really can't hide that too much. So have an understanding of where those different muscles are located. Because if you're documenting, like I did today, I gave a patient, I was on an ambulance today for the first time in a little while, and I gave a patient some Toradol intramuscular because she had some hip pain. So I gave it in the deltoid, 30 milligrams. I gave intramuscular in the deltoid and left side. So my documentation stated that it was intramuscular injection or IM injection in the deltoid. So having an understanding where those muscles are located in the gluteus maximus or the vastus lateralis, right? So the outside muscle of the leg. All right. The musculoskeletal system has several functions. A person's ability to move and manipulate the environment is made possible by the contraction and relaxation of this system. Another function of the muscle is to protect the structures underneath them. So they have to have an energy source. And what is energy? Adenosine triphosphate, right? Some muscle fibers have just enough ATP for short-term contraction. And ATP must be regenerated using existing ATP molecules within the cell. That goes back to us redoing or making adenosine triphosphate in those molecules. Remember back in the beginning of the presentation. Okay. So when ATP breaks down, energy from creatine phosphate is then transferred to ADP, right, molecules to convert them back to ATP, right? ADP is adenosine diphosphate, right, and phosphate. So it regenerates back around in a circle, okay? Goes from di to tri. All right, so as far as oxygen goes, all right. So oxygen is required for the breakdown of glucose in the mitochondria. One hemoglobin molecule reversibly binds with 4 oxygen molecules. Hemoglobin being transported through the blood, oxygen attaches it by 4. Right? So if you had oxygen here, right? Change that. We have hemoglobin here, and it attaches, let's say the hemoglobin molecule, we have oxygen, 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 oxygen. Okay? And that's going to transport through the bloodstream, right? The pigment myoglobin is synthesized in the muscles and that can combine with oxygen to temporarily store and reduce muscular requirements. Lactic acid is a byproduct of anaerobic metabolism and can accumulate in muscles. It will often diffuse in the bloodstream. So why would that be important, especially for somebody who's been on the floor for a long period of time, like elderly, right? And what can that cause with that muscle breakdown? Anybody know what that's called? You know that muscle breakdown and what can actually go in and hurt the kidneys and everything else? ever heard of rhabdomyolysis before? All right, we'll cover more of that later, but keep that in the back of your head for rhabdo. Right. All right. So oxygen depth is equivalent to the amount of oxygen that the liver cells require to convert lactic acid into glucose, as well as the amount needed by muscle cells to restore ATP and creatine phosphate levels. All right, so the sensation of muscle fatigue occurs when energy supplied to the muscle is inadequate to meet the energy demands. Right, this is and if you look in your books on table 7.5, this lists the changes in muscular metabolism. All right, respiratory. All right, the respiratory system consists of all the structures of the body that contribute to respiration. Upper airway. You'll probably see this on a test, the difference between upper and lower airway. The upper airway includes the nose, mouth, tongue, jaw, oral cavity. Obviously, the nasal cavity is part of that as well. The larynx and the pharynx. Sounds are created as air flows past the vocal cords. What's another function of the vocal cords? What does that do for us? Very important for paramedics to know this, but as advanced EMTs, what function does the vocal cords provide?
Landmarks for intubation.
What was that? Sorry.
Landmark for intubation.
Well, that'd be your glottic opening, right?
Yeah.
But what does the vocal cords actually do though? What does it create? What do you guys think?
Doesn't it close off the esophagus?
No, that would be your epiglottis, right? Going back and forth, that can close it off for eating and drinking, right? But what about the vocal cords? What's so important other than, it creates sound, voice, but it creates something else. And if something's in its place, like an endotracheal tube, where you could be not intubating, but you could be ventilating a patient as an advanced EMT with an endotracheal tube in place, if you don't have a vent to take over that. All right, by removing the vocal cords, okay, it removes PEEP. PEEP is positive and expiratory pressure. Your vocal cords create PEEP. That allows us to breathe, right? It allows us to take a deep breath in and back out again, still leaving pressure behind, forcing it back out, right? Positive and expiratory pressure keep the lungs open longer. If the vocal cords are no longer present, you lose the ability to make PEEP internally. That's why it's so important. All right. So as the tongue, let me go back a slide here. Did I mess this up? No, we're good. All right, next slide. So the tongue is attached at the mandible at the hyoid bone. The palate forms the roof of the mouth and separates the oropharynx from the nasopharynx. The palate's important to us because we have a hard and soft palate, and that is the landmark in between hard and soft, where you twist and turn an NPA. All right. So the lateral borders of the glottis are the vocal cords. Okay. So again, for paramedics, it's important because we look for the vocal cords in the glottic opening. Right. The nose and the mouth lead to the oropharynx. The nostrils leads to the nasopharynx. The olfactory receptors located in the epithelium in the nasal cavity are responsible for recognizing odors. Right. The esophagus and the trachea are located at the bottom of the pharynx, and the epiglottis is a leaf-shaped valve that allows air to pass into the trachea, but prevents food and fluid from entering the trachea itself. The thyroid cartilage is anterior part of the larynx. Right. So we mentioned the epiglottis. In pediatrics, what's something that can happen with the epiglottis?
It can swell.
It can swell, and that's called epiglottitis, right? So epiglottitis. And in a fun fact here, if you were looking at an X-ray of a pediatric with epiglottitis, you're looking for something called thumbprint sign, and it looks like a thumbprint being pushed because of the swelling of the epiglottic. It's pretty neat to see. Not for the kid, but pretty cool if you're into medicine. All right. So let's look at this here. All right. Air comes in, nose and mouth, right? Inside the nose, we have something called turbinates. There's 3 different routes of turbinates that come through the nose, right? Come into the nasopharynx, into the oropharynx. Air comes in through the mouth, through the oropharynx here as well. It goes down in through the trachea, right? Through the the glottic opening, through the vocal cords down the trachea, right? As it passes down through, air comes in, it branches off. This is called the carina. I was asking what it is, but it's actually labeled, right? So it comes down. This is the apex of the lungs up here. And air comes in through the bronchioles, the main bronchus, into the bronchioles, which are all these different passageways here. And at the end of each passageway, it breaks it down into the alveoli. The alveoli is where that gas exchange happens. We have the oxygen coming in and the bad stuff coming back out, the carbon dioxide, and that's as we exhale. As we're exhaling and all this stuff is coming out like this, right? Coming out through here. If we have waveform capnography placed with the here, we can measure how much carbon dioxide is coming out and if the body is being perfused appropriately, right? We need to make sure that this is becoming perfused and our body is perfusing as need be, right? Now, in the alveoli, there are little air-filled sacs all over the place, right? And within that sac, it has to be elastic, right? Elasticity. It has to be able to expand and contract, right? What lubricant helps assist that expanding and contracting? Begins with an S. Something that's taught in EMT school. Good refresher. I might spell it wrong, but surfactant. Has heard of that before? Okay. Surfactant is that lubricant that allows for the elasticity of the alveoli. Right? If we lose that elasticity, right, and the surfactant is gone, and we have alveolar collapse, what is that called? Anybody know what that's called? Keep in mind, a lot of this stuff I'm talking about is BLS review from the basic EMT school. Here's a hint. Begins with an A. It's okay if you forgot to. That's why we review this stuff. Anybody know what it's called? Atelectasis. Atelectasis is alveolar collapse. Right? So if we lose that surfactant and we have alveolar collapse, that part of the lung is no longer working. This can turn into a pneumothorax. Okay, we can have a collapsed lung because of it. All right. So the lower airway consists of the trachea, the bronchial tree, the alveoli, and the lungs. This is where that gas exchange happens. So the inferior aspect of the thyroid cartilage articulates with the cricoid cartilage or cricoid ring. Right? Important to know. In a pediatric, see the rings going around the trachea here? Right? They're not fully developed in a pediatric, which is why which makes it more pliable, which is why we have to pad underneath the head to keep that trachea open in the ped. Right? In adults, we can bend the head forward and backwards, and because the cartilaginous rings are more solid, right? It makes the trachea a more solid part of the anatomy, right? Otherwise known as the windpipe. All right. The main bronchi, the bronchioles, going right down through into the very air-filled sacs at the end. Right, that's where the gas exchange is actually happening. The cricoid cartilage is the first ring of the trachea. Right, at the level of the 5th thoracic vertebra, the trachea branches into the right and left main stem bronchi at the carina. Beyond the carina, air enters the lungs through the right and left main stem bronchi. So the point of entry for bronchi, blood vessels, and nerves into each lung is called a hilum, Hilum, the hilum. The main stem bronchi divides into smaller secondary bronchi, and the secondary bronchi branch into even smaller tertiary bronchi. And after that, after several generations of successive branching and bronchioles, extremely small subdivisions of bronchi are now formed. Each bronchiole divides into 4 alveolar ducts. Each alveolar duct end has clusters known as alveoli. Right? So the pulmonary surfactant found in the alveoli reduces the surface tension to increase pulmonary compliance and prevent atelectasis at the end of expiration. Right? So the pulmonary capillary membrane lies between the alveolus and the capillary, also called the alveolar capillary membrane. Right? So why is all this important? Why I just mentioned a bunch of stuff and all these different ducts and branches and everything else. Why is this important to us? There's 2 things that makes this very important. What are they? I'll write them down for you too. Perfusion, oxygenation. This is why it's so important for us to have an understanding of how this stuff works. Knowing how perfusion works, how to read waveform capnography, looking for that bronchoconstriction waveform, right, will help us determine what medications we're going to administer to treat these patients. Bronchodilators, right? That's what we're going to be administering. CPAP, right, which is a BLS skill, right? This is going to help with that perfusion and oxygenation status. We're going to see changes, right? That's why it's so important to have an understanding of how these work, right? A patient that is in bronchoconstriction with shark fin waveform, right, means that the alveoli are not releasing all at the same time, not allowing for good oxygenation, which means something is clogged somewhere with mucus, and that's going to help with bronchodilation, giving a bronchodilator. But and I'm kind of going a little off topic, but I'm not. A bronchodilator, being a pathomimetic, will have different side effects, right? Other than bronchodilation, it has some beta 1 properties, which would increase heart rate. Okay. This is why it's so important to have an understanding of what is going on inside the body when you give a medication inhaled, right? Another thing that also happens when you give someone albuterol, not enough of what you'd be giving, but a lot of albuterol pushes potassium out of the cells, and it can move potassium around. Okay, this is why one of the treatments for crush injuries for a paramedic is 20 milligrams of albuterol inhaled to help with that potassium push. So yes, you're not going to be doing that in the field as an AEMT, but you are giving albuterol, which can facilitate in potassium movement. Also facilitates an increasing heart rate and bronchodilation. Are things starting to come together a little bit now with what you're doing? Remember that I can't see all of your pictures, so yes, right? Everything ties in with cause and effect of what's going on. All right, so surrounded by the membrane of connective tissue known as the pleura, the parietal pleura lines the pleural cavity and covers the thoracic wall and superior face of the diaphragm. The visceral pleura covers the external surface of the lungs. A potential space known as a pleural space exists between the visceral and parietal pleura. Okay. Now, looking at the lobes. Okay. You notice we have an upper, middle, and lower lobe, and an upper and lower. This is the right side. This is the left side. Okay. Why are there only 2 lobes on the left? What takes place of one of the lobes?
That's where the heart is.
Exactly. So your heart is going to sit. If I can draw it right. Kind of sits like that. Okay. Then you have the mediastinum, which is here, right down through. This is your visceral pleural things in the diaphragm coming down. These are the trying to remember the name of it, I'm drawing a blank. Something notch. I'm drawing a blank of it. I'll think of it probably after I'm done with the slide. Then you have upper, middle, and lower lobe, upper and lower lobe here. heart sits here, mediastinum is here. Why am I mentioning that? Because you can have airfill inside the mediastinum. That's what they call a pneumomediastinum. Nothing we're going to be able to do in the field for that. We need to go to the ERs for those. Okay, it's going to be more of a intervention done at the hospital. Right. So primary muscle of the diaphragm. The diaphragm is unique because it has characteristics of voluntary skeletal and involuntary smooth muscles. Right. Smooth muscles being within the lungs. Right. Let's see. So the diaphragm performs an automatic function. Right. So the other function muscles involved in breathing are the intercostal muscles, abdominal muscles, and pectoral muscles. During inhalation, the diaphragm and intercostal muscles contract. During exhalation, the diaphragm and intercostal muscles relax. So the process of breathing is typically easy and requires little muscular effort. Chronic bronchitis, so inflammation of the bronchioles, results in overgrowth of airway mucus glands and excessive secretion of mucus. Emphysema results in the destruction of alveolar walls, which then creates resistance. Okay, otherwise known as COPD. We've heard of that before, right? Yeah, COPD. Right? These patients have a hard time breathing. Another thing you're going to see with patients with emphysema is what they call increased AP diameter, otherwise known as barrel chest. Now people are like, yeah, we've heard of that before, right? What they call an increased AP diameter of the chest, the barrel chest. Those are patients that have chronic emphysema. These are the COPD patients. Okay. Their norm is going to be right around 89% on oxygen usually, or 90%, and that's perfectly fine for them. But if they're short of breath and you increase their oxygen to 98, 99% for a short term, it's okay, right? These patients here will probably end up getting CPAPs by an advanced EMT, okay? We'll talk about that more in respiratory. The respiratory system primary function is to exchange gases at the pulmonary capillary membrane or to conduct respiration. Respiration is diffusion, is the process by which a gas dissolves in a liquid. Oxygenated blood then enters the left side of the heart. Okay, remember, right side is deoxygenated, going through the different valves into the lungs through the pulmonary artery, and then back to the pulmonary vein, right? Back and around. Pulmonary vein carries oxygenated blood. Lost my connection again. Right? And it then is pumped into the tissues. Because there are so many alveoli, a fairly large surface area exists for respiratory exchange to occur, as you can see here. This figure shows the oxygen exchange occurring capillaries in the lungs. Oxygen then passes the blood to the tissue cells, and carbon dioxide and waste pass from the tissue cells onto the blood. Right? This is where we exhale, as you can see here. Right? So oxygen comes in, dissolves into the tissue cells, which then will pass around through the bloodstream. The bad stuff comes out, carbon dioxide, and this is exhaled through the lungs and out through the mouth, right? As you can see looking here at the pulmonary flow. And we'll talk about in respiratory emergencies, different diseases that can block this flow and make these changes. So the chemical control of breathing in the respiratory center in the brainstem controls breathing. The main respiratory stimulus is accumulation of carbon dioxide in the blood. This is what stimulates it. We'll talk about this here in the next slide. Low blood oxygen levels also stimulate breathing. A decrease in pH of the arterial blood that is caused by an elevation in the PaCO2 is called the primary respiratory acidosis. An increase in pH of the blood that causes by excessive exhalation of carbon dioxide is called primary respiratory alkalosis. So changes in a PaO2, which is partial pressure in the arterial pressures, may occur in response to primary metabolic problems. These are called compensatory changes. The body also has a backup system to control respiration called the hypoxic drive. Right? Let's get into this here, okay? Acid is a substance that increases in the concentration of hydrogen ions in a water solution. A base is a substance that decreases the concentration of hydrogen ions, and the most common expression of acidity is pH. When the pH is higher, the blood is too basic or alkalotic. When the pH is lower, the blood is too acidic or acidotic. Why is this important? Okay. Looking at this stuff here, we sit between this. Okay. We sit just a little alkalotic. Okay. Now, remember before I mentioned absolutes. Absolute normal is 7.40. We in EMS look at the range. Okay. 7.35 to 7.45. Right. So if we have a patient, and here's the respiratory side of things, if we have a patient that is breathing too slow, right, otherwise known as bradypnea, okay, bradypnea, breathing too slow. Let's just say we have, we're going to draw this out here. Here's our line. This is 0, right? This is 60 on top, and we have waveform, and the patient's breathing, let's say 6 times a minute. You're going, okay, and remember, our normal is right around here. Let's say this is 40. That's our normal waveform. You're going to see waveform come up to about 60 and back down again. Okay. These are going to be patients that are hypoventilating. Patients that are hyperventilating, okay, are now retaining, causing, let's say we have the 60, 0, 40 being here. We're going to see lower numbers like this. It'll be in a faster pattern, but below the 40 line. So you'll see numbers around, let's say, 18 or so, 20. You'll see it lower. Hyperventilation, lower numbers, right? Becomes very alkalotic. Okay. So I'm going to put down here ALK. These patients here that are hypoventilating have an increase in pH, causing a patient to be acidotic. Right? So why is this important for us? Right? We need to meet homeostasis in the pH world. Right? So how do we fix this problem? It's very simple. How do we fix it? You guys ready for this one here? BVM. Control the respiratory drive. Control it. Okay. If you have a patient with a head bleed, head trauma, okay. If you call for DART, you call for life flight, they RSI, they intubate, they all do all these cool paralytics and sedatives and everything else. You're like, oh, these guys are awesome. And they drop the tube, right? They're looking for these numbers. Okay. Now you've always heard never hyperventilate a head trauma patient, right? You guys have heard that? Never underventilate a head trauma patient, right? So how do you know what to do? Am I supposed to do normal? Am I supposed to go high? Am I supposed to go low? I don't know, right? It's all based on numbers, right? If the patient's intubated, right, you're going to watch your end tidal. The goal for end tidal for a patient with head trauma who's intubated is 35, right? By doing that, breathing too fast, okay, if the patient has a high end tidal reading for these patients, right, we're constricted. I'm sorry, dilated. If we're too low, we're constricted in the vessels in the brain. We can control constriction and dilation just by looking at end tidal CO2 readings and ventilating a patient with a BVM. That's why it's important to have an understanding of how acid-base balance works, because it also controls vasodilation, vasoconstriction, based upon how much your blood is acidotic or alkalotic, can make those changes. Does that make more sense now? Everything's tying in together here, and why it's so important to understand the respiratory system. Because without knowing this, all we're doing is cookbook medicine. I don't want you guys to do cookbook medicine. I want you guys to be a clinician, understand the whys of what you are doing, and we can control the outcome. Hopefully, that's the plan, by looking at end tidal CO2 waveform capnography and kind of seeing where our patient is sitting in a perfusion status. All right. So the buffer system is a compound that repeatedly neutralizes, right, the excess acids or bases. Buffers absorb hydrogen ions when they are in excess of and donate hydrogen ions when they are depleted. Right? This is what we call bicarb. Another name for it here is HCO3. That's bicarb. Our normal range, 22 to 26. Okay, now we know our pH. Normal range is 7.35, 7.45, and we know our EtCO2 range is now 35 to 45. Okay, if I were you, I would memorize these numbers and know these by heart, because this right here is acid-base balance. And you are going to see this on your National Registry exam. All right. Now here's the difference. All right. This is why it's taking so long. Whatever we don't finish tonight, I'm not sure we'll be able to finish. Hopefully we will, but I'm going to go. What slide is this one here? 68. All right. I'm going to do this for a minute. I'm going to go to a blank slide. All right. I want you guys to understand that you're going to see this on your exam, and it's going to become confusing if you don't understand it. I'm going to put down the numbers. Okay. Ah, goodness. Okay. Can you guys read that? Metabolic, right? Ah, my finger touched the screen. Respiratory, you guys see that? So I'm going to ask you guys a bunch of questions here with these numbers being in place. Okay. Remember that anything above A here, that's acidotic. That's alkalotic for this one here. Okay. Bicarb, elevated bicarb, acid. All right, alkalotic, we look at that here. Anything lower than 7.35 is ALK. Or rephrase that, is acid. Anything above 7.45 is alkalotic, okay? You guys got that so far? So what if I told you this? That a patient, we'll say patient here, has a pH of 7. Can't write. 7.26, all right, end tidal, right, of 60, a bicarb of 24. Okay. 7.26, is it acidotic or alkalotic?
Acidotic.
Okay. Is the end tidal acidotic or alkalotic? Or is it normal?
Acidotic.
Okay. Is the bicarb normal, acidotic, or alkalotic?
It's normal.
Normal. So this patient here is going to be something called a respiratory acidosis. Okay. You guys see where I got that from? You have to know your numbers, right? This is a respiratory acidosis. If this was, let's say, 34, this would be a compensated metabolic acidosis with respiratory involvement. Okay. I don't have, do you guys really know about the compensation part? What you need to know is how to differentiate respiratory and metabolic acidosis and alkalosis. If the pH is 7.56 with a bicarb of 32 and an end tidal CO2, right, of 40, acid or alkali?
Oh,
It's elevated, right?
yes.
High or low?
I,
High,
Yes.
normal, high or low?
normal.
Okay. This would be considered a
Metabolic acidosis. Alkalosis.
alkalosis, right? Metabolic alkalosis. Why? Because the bicarb was off and the pH was off and the end tidal was normal. Okay. You guys got that? If I had more space, I'd show you guys a tic-tac-toe method. We can use a tic-tac-toe board to make it work. It's pretty neat how that works too. I wanted to make sure I went over this a little bit with you guys because you're going to see this again on your national registry where it's going to give you a bunch of numbers and you're going to give an answer. Is it respiratory or metabolic alkalosis or acidosis? And you have to know by looking at the numbers that are there. Right? And then how do we treat it? Well, if it's metabolic at the advanced EMT level, we're not going to treat it. But respiratory, we can. We have BVMs, we have CPAP, we have a bunch of different things that we can utilize to change that outcome. All right? Does that make sense? Right? You guys have any questions about it? Good. Please ask because this is very important when it comes to respiratory because we get a lot of those types of calls. All right. Let's just plow through this and see how much farther we can get. All right. So ion shifts, a concentration of hydrogen ions, so H positive, right? Can be increased by adding more hydrogen ions to a solution by removing OH negative. To make a solution more acidic, a higher concentration of hydrogen ions and a lower concentration of OH are needed. If the solution needs to be more basic, meaning increasing the pH level, there are two options. One is decrease the amount of hydrogen or decrease the amount of OH negative. Acids can be classified as strong or weak depending on how completely they dissolve in water, right? So to function properly, acid-base balance must exist on both sides of the cell. Calcium ions also shift out of the cells in response to influx of hydrogen. So an increase in extracellular hydrogen ions result in acidosis, and a decrease in extracellular hydrogen ions result in alkalosis. All right. Did that make any sense to you guys at all? It's okay if it didn't. That's why I went over the other thing I just went over with you, right? That's what you guys really need to understand. There are three main components to the buffer system. Circulating bicarbonate buffer component holds and neutralizes excess acid found in ICF and ECF and is the fastest acting segment of the buffer system. Carbonic acid, H2CO3, is a weak acid that can give up an extra hydrogen ion to reform as a bicarbonate HCO3. We just talked about that, right? Your bicarb, your normal range being 22 to 26. So the extra hydrogen ion is then converted into compounds that are easily expelled from the body, eliminating the extra acid. A patient in cardiac arrest is in a metabolic acidosis. So I'm sure you guys have heard before sodium bicarb being given at the end of a cardiac arrest. It's because we're trying to reset that buffer system that's there. Last ditch effort, people give an amp of sodium bicarb and they hope that they can get a pulse back. Right? So the respiratory component, the fastest way for the body can get rid of the excess hydrogen ions is to create water and carbon dioxide, which is going to be expelled as a gas from the lungs. Right? Monitoring that through end tidal. The renal component, kidneys maintain homeostasis by retaining certain products and filtering out the others. All right, this could take a form of hours to days to restore the body's pH to normal. This can be controlled in increasing acid levels in the blood by excreting acid. So patients that can no longer function, that are in acute renal failure, get what? To help excrete this and clean the blood.
Dialysis.
There you go. Now are things starting to make more sense? All right, nervous system, control of breathing. The medulla oblongata, right, water boy, right, is primarily responsible for initiating the ventilation cycle and is primarily stimulated by high carbon dioxide levels. So as the carbon dioxide goes up, it stimulates to breathe. The medulla has two main portions that control the breathing: the dorsal respiratory group, the DRG, and the ventral respiratory group, the VRG. The DRG is the main pacemaker for breathing and is responsible for initiating respiration, where the VRG helps facilitate forced inspiration or expiration as needed. The pneumotaxic, or the pontine center, located in the superior portion of the pons, helps shut off the DRG, resulting in shorter, faster respirations. The apneustic center, located in the inferior portion of the pons, stimulates the DRG, resulting in longer, slower respirations. Right? So the Herring-Bauer reflex stops VRG, pneumotaxic center, and apneustic centers from accidentally causing lung trauma. That's called a Herring-Bauer reflex. Hint, hint, memorize what that is. All right. Perfect. So as far as lung volumes go, tidal volume is the amount of air that is moved into or out of the lungs during single breath. Inspiratory reserve volumes are the deepest breath you can take after a normal breath. All right. Reserve volume, 3,000. Residual volume, 1,200. Expiratory reserve volume, 1,200. Tidal volume, 500. All right. Here's an equation you guys might help you out a little bit here, okay? Lung volume, 4 to 6 milliliters per kilogram. Ideal body weight. That's how much air you should be giving as a number. Okay. Kind of a little helpful hint. All right, expiratory reserve volume is the maximum amount of air that you can forcibly breathe out after a normal breath. Residual volume is the amount of gas that remains in the lungs to keep them open. Vital capacity is the amount of air moved in and out of the lungs with maximum inspiration and expiration. Right? Dead space is a portion of respiratory system that has no alveoli. That's considered your dead space. And then all this stuff will come back around during respiratory emergencies. We start talking about pneumonia and different other lung disease like RSV, different lung diseases that are there. That will change a lot of this, right? So the depth of each breath is critical information to know when assessing ventilation. Great. And we can monitor this with end tidal. Minute volume is the amount of air that moves in and out of the lung in 1 minute. Minute volume. Characteristics of normal breathing. Another name for it would be called eupnic. So eupnic breathing is normal breathing. The normal rate and depth of tidal volume. Normal regular rhythm pattern of inhalation and exhalation. Good audible breath sounds on both sides of the chest. Regular rise and fall movement of both sides of the chest and movement of the abdomen. This is what we are looking for. Not just saying, oh, I see the chest moving. Is the abdomen moving? Is the chest moving? Are lung sounds present? Right? There's 8 spots in the back and there's 4 spots in the front that we're going to assess on every patient when assessing lung sounds. Right? And here's my little notes here. I was going to show you guys the oxygen dissociation curve on this one here, but I figured that acid base would be a little bit better to do. I was going to draw out the curve for you, but that's okay. We need another day. All right, so complex arrangements of tubes connecting one to another to a pump. This is our circulatory system, right? This is entirely closed, and there are 2 circuits in the body. There's a systemic circulation and then the pulmonary circulation in the lungs. This figure here kind of shows you what it looks like. Blue is deoxygenated. Red is oxygenated. Okay. How do you guys feel with the circulatory system so far? You guys feel okay with it? All right. I don't see everybody on the screen, so I'm guessing everything's good. All right. So the heart, muscular organ that pumps blood throughout the body, located behind the sternum about the size of a closed fist. Not my fist, the fist for yourself, about the size of your heart. Approximately 2/3 of the heart lies in the left part of the mediastinum. The heart muscle is called the myocardium. The pericardium, pericardial sac, right, is a thick fibrinous membrane that surrounds the heart and the base of the great vessels. The visceral layer of the pericardium lies closely against the heart and also is called the epicardium. The second layer of the pericardium, the parietal pericardium, is separated by the visceral layer by the small amount of pericardial fluid that reduces friction with the pericardial sac. The endocardium is the inner lining of the heart, and the interarterial septum separates the 2 arteria. The intraventricular septum separates the right and left ventricles. Remember, each atrium receives blood that is returned to the heart from other parts of the body. Each ventricle pumps blood out of the heart. The semilunar valves are located between the ventricles and the arterioles into which they pump blood. Blood enters the right atrium into superior and inferior vena cava and the coronary sinuses. The blood from the 4 pulmonary veins, right, enter the left atrium. Right? Remember, the pulmonary vein now has oxygenated blood. Pulmonary artery has deoxygenated. It's opposite. Right? The only other one that would be opposite like that has that's different is the umbilical cord. We'll get to that in obstetrics. Right? Between the right and left atria is a depression called the fossa ovalis, which represents the former location of the foramen ovale. Okay? We just covered a lot of stuff that's there. Right? This figure here shows the anatomy of the heart. Right? You can see the great vessels up here. Great vessels. Coming through, this is your inferior and superior vena cava. All the oxygenated blood. Right? We have the right atrium here. This is the right ventricle. Let's see the left atrium. It's kind of behind here. The left atrium, left ventricle. So when this part of the heart squeezes, okay, on an EKG, just to kind of talk about this really quick, right? We have our P wave, QRS, T wave. When that squeezes, that's this right here. Okay. The electrical conduction system causing that to squeeze. That's a QRS wave. We'll cover EKG stuff later, but I just want to kind of point that out to you guys. When you feel a pulse, that's your left ventricle squeezing. When you feel the pulse beat. All right. Last thing here. Outer layer of the heart. What is that called? What's the outer layer of the heart? It's in a sac, right? Pericardial sac, pericardium,
yeah.
pericardium, right? If a patient has pericarditis, What would that be?
Wouldn't that be fluid around the sac?
Otherwise, pericarditis being an inflammation of the pericardium, right? So what triad would you look for that? What was that? Mike, do you have something? I thought you said something. If you have someone with pericarditis, what triad would you be looking for?
Is
Three
it
things.
Cushing?
Not Cushing's.
No, oh,
That's intracranial pressure.
Beck's triad, I believe.
It is Beck's. What are the three things you look for in Beck's? I do this now because this is going to come back to haunt you later. JVD, muffled heart sounds, narrowing pulse pressures. Pulse pressures being blood pressure. Like this. Your systolic, diastolic. Okay. Something close together. What's the treatment for this? Get them to the hospital. They need a pericardial centesis, big long needle to the heart, which is usually ultrasound guided going in. Okay. That was pretty cool. I did that in a cadaver in November. But this is what you look for here. Beck's triad. Okay. Enough of that. All right. So the heart valves consist of blood passing through the atrium to the ventricle flows with 1 to 2 atrioventricular valves. The tricuspid valve separates the right atrium from the right ventricle, and the mitral valve separates the left atrium from the left ventricle. These valves consist of flaps called cusps. The papillary muscles attached to each ventricle then send small muscular strands called, chordae tendineae to the cusps. The two semilunar valves, aortic valve, pulmonic valve, divide the heart from the aorta to the pulmonary artery. The pulmonic valve regulates blood flow to the right ventricle to the pulmonary artery, where the aortic valve regulates blood flow from the left ventricle to the aorta. Hint, hint, know the valves that are there. The valves in the chambers and the electrical conduction system. All right. Blood flow within the heart. Superior vena cava and inferior vena cava then return deoxygenated blood to the body or from the body to the right atrium. Freshly oxygenated blood then is returned to the left atrium through the pulmonary veins. Then blood flows through the mitral valve into the left ventricle, which pumps oxygenated blood through the aortic valve into the aorta and then to the entire body. The left ventricle is the strongest and largest of the 4 cardiac chambers, right? So when you're listening to hard sounds, there's just something called what they call an S1, S2. All right, S1, S2 would be the lub-dub sound, okay? Created by the contraction, relaxation of the heart and blood flow. This can be done through auscultation with a stethoscope over the heart. The S3, S4 sounds are not usually heard in people with normal heart functions. 4 other sounds, all abnormal, may be heard when auscultating the heart and great vessels. A murmur is an abnormal whooshing sound heard over the heart that indicates a turbulent blood flow of the heart. A bruit is an abnormal whooshing sound heard over the main blood vessel that indicates turbulent blood flow within the blood vessel, and both clicks and snaps indicate abnormal cardiac valve function. Right, one called something like Tennessee, and some other ones as well that you can listen for. But the big ones to listen for are the S1, S2, the lub-dub. Right. Do not do this in the back of a moving ambulance. You're not going to hear it very well. These are the ones you do inside of a house. Listen to the lungs, listen to heart sounds. Why? Because if they're muffled and they have JVD and narrowing pulse pressures, pericarditis. Right. So the electrical conduction system, mechanical pumping action of the heart that occurs in response to electrical stimulus. The brain partially controls the heart rate and strength of the contraction via the autonomic nervous system, right? The contractions are initiated with the heart itself in a group of complex electrical tissues that are part of a conduction system. And this is what you guys need to know. The cardiac conduction system consists of 6 parts: the sinoatrial node. All right, I'm going to write this down here really quick. 60 to 100. We'll get back to that in a second. The atrioventricular node. Okay. The bundle of His, the right and left bundle branches, the Purkinje fibers. All right. As well, the sinoatrial node is the normal site of origin for the electrical impulse, the original portion of impulse. Electrical stimulation of the heart muscles then continue toward the bundle of His down the bundle of branches and terminates in the Purkinje fiber. So why did I write down all these different numbers? These are what they call intrinsic rates. All right. The SA node has an intrinsic rate of 60 to 100. Imagine that the adult heart greater than 100 is tachycardia, greater than less than 60 is bradycardia, the intrinsic rate. If this happens to fail, the SA node fails, your AV node then takes over with an intrinsic rate of 40 to 60. It's your backup generator of the heart. All right. If the AV node fails, you have another backup generator. Your body's not going to perfuse very well. This is what they call, I'm going to write the PERK. These are the Purkinje fibers then taking over with an intrinsic rate of 15 to 30. Depending on what book you read, it could be 44, it could be 22, right? I like 15 to 30, right? So you have backup generators with this. What's happening is your SA node, okay, fires. See those little green arrows in there? Those are called intrinsic pathways, right? The intrinsic pathways are going to go to the bundle of His, right? Where the AV node is then also kept as well. It then transfers and fires down the heart into the right and left bundle branch. And I'm sure you've all heard of bundle branch blocks before at some point in time in your career. That's where the blockage is, right? It then transmits down, goes around the side, and these Purkinje fibers through here and causes that ventricle stimulation, causing it to contract, right? To constrict, causing that blood flow to go. This is part of the conduction system, right? And everything has to resurface. So if I draw this out, you get your P wave here, P wave, QRS, T wave. Don't read into how long that is. That's a different story. All right. When things repolarize, that means they're re-energizing. Okay. So your P wave is your atrial repolarization. Okay. After your atria fires, it has to repolarize. That's your P wave. Your QRS is your ventricle depolarization. That's your ventricle squeeze. Because it's so powerful, right? The atria is repolarizing underneath it. You just can't see it. And your T wave, so we'll have P here. This is QRS. And this one here is your T wave. This right here is your ventricle repolarizing, building up energy again to then cause the next firing. Okay. That's how the conduction system works with the cardiovascular system pumping blood. Right. Now, there are times where this is not going to work together and you're in cardiac arrest. And that's called PEA, or pulseless electrical activity, where there's still activity, but there's no pump. Okay. What I need you guys to understand with this here is without an electrical conduction system, your heart cannot pump. And looking at an EKG, this is the breakdown. I will go over EKG with you later and how to truly look at those. Okay. But in the meantime, this is how it works. All right. So the heart's chronotropic state, dromotropic state, and inotropic state are provided by the brain via the autonomic nervous system. Baroreceptors respond to change in pressure, usually within the heart or the main arteries. Chemoreceptors sense changes in chemical composition of the blood, and stimulation of receptors often cause activation of either the parasympathetic or the sympathetic branches of the autonomic nervous system, affecting both the heart rate and contractility, right? So here you go. This is something you need to know for medications. Alpha effects result in vasoconstriction. Beta effects result in increased inotropic, dromotropic, and chronotropic states. We're changing rates. All right. So the cardiac cycle, the process in which it creates the pumping of the heart. So systole, right? Contraction of ventricle mass, pumping blood into the systemic circulation. Diastole, relaxation of the phase of the cycle. And pulse pressure is the difference between the systolic and diastolic pressures. My goodness, we just talked about narrowing pulse pressures. It all comes back, right? Good. Afterload is the pressure in the aorta against which the ventricles must pump, right? So the greater the afterload, the harder it is for the ventricle to eject blood into the aorta, reducing the stroke volume. Cardiac output is the amount of blood pumped through the circulatory system in 1 minute. All right. So Starling's law of the heart. Increased venous return to the heart stretches the ventricles, resulting in increased cardiac contractility. The ejection fraction, which is the percentage of blood pumped out of the left ventricle on each contraction. Preload is pressure under which the ventricle fills. So why is that important? When we start talking about right-sided MIs, inferior wall STEMIs. When they do not have an afterload issue, they have a preload issue. So giving a patient nitro that has a right-sided MI or a inferior wall will cause the tank to become bigger with no fluid in it. And what's going to happen? You're going to tank their blood pressure. You're going to kill your patient. So just because they have chest pain with a blood pressure of 100 systolic does not mean it's right to give somebody nitro. Because if you do an EKG at 12 lead and the computer interpretation states inferior wall MI, withhold that nitro because it's not a vasculature issue, it's a preload issue. They need fluids, like 2 liters of fluids, right? Just like a patient in shock. You can give pressors, paramedics can give pressors all they want, but they can't squeeze if there's nothing in it. You got to have fluids first, right? Perfect. So the vascular system, the blood is transported through the body in the arteries and veins. So the arteries branch into many small arterioles and divide into further into the capillaries. This is all BLS review. So walls of the blood vessels are then composed of 3 layers, right? There's a smooth, thin layer called the tunica intima, or the endothelium, right? The middle layer, the tunica media, composed of the elastic tissue and smooth muscle cells. And the outer layer is called the tunica adventina, which consists of the elastic fibrous connective tissue, right? I can guarantee you're going to see this on an exam. The circulation of the heart, supplied by coronary arteries, emanates the left and right coronary arteries. Right coronary artery divides into 9 important branches. The left main coronary artery is the largest and shortest of the myocardial blood vessels. This divides into 2 branches, the left anterior descending, or the LAD artery, and the circumflex coronary arteries. So why is all this important? This is how our heart stays oxygenated, right? And if I had a blank slide, I'd show you guys the 12 lead, because looking at a 12 lead where you have infarction can actually tell you which potential artery is actually clogged. All right. We go over that another day. I just want to keep going because it's not really part of this lecture. So we'll do that more in cardiology. The pulmonary circulation carries blood within the body and the right side of the heart to the lungs and back to the left side of the heart. The oxygenated blood is then carried from the right ventricle, is pumped through the pulmonic valve into the pulmonary artery, where now we're picking up all the oxygenated blood going into the left atrium, into the left ventricle. So our systemic circulation, right? So there are 3 major arteries that arise from the aortic arch: the brachiocephalic, left common carotid, and the left subclavian. Here's a little hint on the subclavian artery. right? Next to it is called something called the subclavian vein. If you do a humeral head IO, it's like doing a central line. Humeral head IOs have direct access to the subclavian vein, which is a direct access to the heart. It's actually a better location for interosseous access. All right. This figure here, if you can read it, I know that I cannot on my screen because it is way too small, are all the different arteries and veins, major arteries and veins. You should have an idea of most of these, where these are located, because you're going to be going into intravenous access, right? So know where your different veins are located. Because you may have that patient that's obese and you cannot feel or palpate, but having an idea where things go, I don't want you fishing for an IV, but know the anatomy layout, and you might be able to find something pretty easily, right? Know where those things are located. As far as pulses go, remember that we have carotid pulses, right? We have brachial, radial, femoral, popliteal, tibial, and dorsal pedal. Those are all different pulse locations you should be familiar with for arteries. All right. Any questions on that at all? You mean to go down through those different pulses again? You guys pretty good. Just know where they're located. If you need me to go over them, I can. Hearing nothing, we'll move forward. All right, so the head and neck, the brachiocephalic artery is the first vessel to branch from the aortic arch. All right, as you can see down below the bottom of the neck. And you can see the subclavian artery going as well. Each common carotid artery branches at the angle of the mandible into the internal and external carotid arteries. This point of division is called the carotid bifurcation. All right, it's part of the vascular system. The upper extremity, the subclavian artery, supplies blood to the brain, neck, anterior chest, and shoulder. All right. So the shoulder joint, it becomes the axillary artery and then the brachial artery below the head of the humerus. All right. Perfect. As you can see here, looking at the arm. The thoracic artery, made up of the visceral arteries and the parietal arteries. The visceral arteries supply blood to the thoracic organs. Kind of important to keep those. Yeah, I just lost my train of thought. It's very important to make sure we keep these things oxygenated, right? And perfusing appropriately. That's what I was looking for. So the parietal arteries supply blood to the thoracic wall. Intercostal artery branches into the anterior, posterior intercostal arteries. And then the anterior intercostal arteries originate as branches of the subclavian system. Right. So the posterior intercostal arteries arise directly from the aorta. So as you can see here, how important it is for the abdominal aorta to come down. And you can kind of see the renal as well, branching off into the kidneys, the renal arteries. So the abdominal artery divided into visceral and parietal or portions. The visceral arteries are subdivided into paired and non-paired arteries. The unpaired branches include the celiac trunk, the superior mesenteric, and the inferior mesenteric arteries. The cephalic trunk then supplies blood to the esophagus, stomach, duodenum, liver, spleen, and pancreas. The superior mesenteric artery supplies blood to the pancreas, small intestines, and the colon, where the inferior mesenteric artery supplies blood to the descending colon and the rectum. So the paired branches of the visceral abdominal aorta supply blood to the kidneys, adrenal gland, and gonads. Right, a lot of arteries for you guys to understand how they work. The pelvis and lower extremity at the level of the fifth lumbar vertebrae aorta divides into two common iliac arteries. The external iliac arteries become the femoral arteries, and the femoral artery becomes the popliteal artery. Remember the popliteal pulse, located behind the knee, right? And at the foot, the anterior tibial, where a pulse location is, also becomes the dorsal pedis artery, which is located between the big toe and the toe next to it. Draw a line up the middle, maybe an inch or so, and usually you can find the dorsal pedal pulse located there. The plantar arteries arise from the posterior tibial artery. So you find the tibia basically right on the ankle, and usually you can find it. If you find those lower extremity arteries and you're feeling for pulses, mark them with a pen so you know how to go back to make sure you're checking CSMs that way. All right. So the head and neck, the systemic venous circulation. There are two major veins that are the external and internal jugular veins. Right, spaces between the membranes surrounding the brain from venous sinuses. The external and external jugular veins join the subclavian veins. Right, remember the subclavian vein is almost like a direct line to the heart. The thorax, the venous drainage, begins at the anterior posterior intercostal veins, which provides a major source of flow to the superior vena cava. As far as the abdomen and pelvis go, all venous drains from the lower part of the body passes through the inferior vena cava, and the internal iliac veins drain from the pelvis. And the external iliac veins drain from the lower limbs. The hepatic portal system, so think hepatic, right? Going into the kidneys and all that, is a liver, sorry, not kidneys, liver, is a specialized part of the venous system that drains blood from the liver, stomach, intestines, and spleen, where both empty into the hepatic veins, which then join the inferior vena cava, right? Remember that the liver, it has very high vascular. It also plays a part in the first pass effect in metabolization of medications, right? Very important to pay attention to. And as you're assessing, remember, you can feel 2 centimeters of the tip of the liver underneath the right rib cage. If it's inflamed, then we have, some kind of liver inflammation, or in the pediatric world, it's one of the first signs of congestive heart failure. Upper extremity, the veins of the upper extremity vary somewhat from person to person in the upper forearm, but these veins combine to form the basilar vein and the cephalic vein. Balsilic vein and the cephalic vein combine to form the axillary vein itself. Why is this all important? Because we can do IVs anywhere from here all the way down to, I'll just draw it down here into the knuckles. I've done them in knuckles before. I've had to find access with a 24 gauge catheter. So having an idea of how these things work, you can actually do bicep veins, forearm veins, the AC here, the anticubitals, things like that. You have different options of different veins you can utilize. All right. So blood composition, we're getting there. Blood consists of plasma of 55% and formed elements or cells that are suspended in the plasma, which is 45%, including RBCs, WBCs, and platelets. So red and white blood cells. Plasma is a watery, straw-colored fluid that accounts for more than 1/2 of the total blood volume. Right? All of the components make about 1%. 92% water, 8% dissolved in substances and proteins, electrolyte, and nutrients. Then we have waste, nutrients, nitrogen, carbon dioxide, oxygen, proteins, water, and anything else you might find in there. The red blood cells are the ones that carry oxygen to the tissue. That's why it's so important to understand your red blood cells, right? Hemoglobin, transport. This contains a protein as well as hemoglobin, which gives them that red color. The erythropoiesis is an ongoing process which RBCs are then made. So those cells designed for destruction composed in the spleen and other tissues rich in cells known as the microphages. The part of the hemoglobin that is not recycled is converted with bilirubin, right? So you're not going to know the levels of all this stuff here. Understand this with white blood cells. This is what fights infection. So patients that are immunocompromised, example, patients on chemotherapy, have 0 white count or 1 or 2, way too low, right? So the normal is usually between 8 and 12. I say 12. It's a lot harder than 12. That's we just use those numbers 8 to 12. And anything above this would show an indication of a possible infection. So the role of an allergic or inflammatory reaction, they also play with that as well. And platelets are necessary for chemical reactions that occur to form a clot. So you have to have platelets. All right. Patients that lack certain factors like factor 8, right, have the inability to clot. Right. So understand, I'm not going to go into all the different factors that are out there, but understand that patients that have like hemophiliacs that lack the different factors for clotting. Okay, and it's good to know, and the patient should know, and they look for those medic alert bracelets as well, right? Because a simple car accident with a patient who can no longer clot can turn into something very, very dangerous. All right. To kind of save on time, I'm not going to go in depth on an entire complete blood composition with you guys. So that'll take another half an hour to go over all this stuff together. As far as blood groups, we have A, B, O, and RH blood groups. Right? Is this important for you guys to understand? A little bit. I would know it, but don't go crazy over it because you guys are not administering blood. But it's good to have an understanding, though, of what they are. Remember, the RBCs contain antigens on their surface. Antigens are substances that, when they take into the body, stimulate the formation of specific protective proteins called antibodies. These are classified as A, B, O blood groups. These groups determine whether the types of blood a person can receive. Right? So a person with a type O blood is called a universal donor. A person with an AB blood is called a universal recipient. And a person that can have an RH factor, and this is RH positive, RH negative, is a specific type of RH antigen present in their blood or not. The presence of RH factor must also be considered during blood administration. Right? Again, you guys as advanced EMTs are not giving blood. This is like another whole lecture in itself, just going into this up here. Understand that there's A, B, and O blood groups. So AB, A, B, and O with RH positive, RH negative antigens. Right. As far as pulses go, we kind of covered all the different pulses that were there. Blood pressures, pulse pressure, blood exerts against artery walls, which you guys should already have an understanding of how that works. Remember that the other name for a blood pressure cuff is a sphygmomanometer, which measures the high and low points of a wave. Right? If you're checking a carotid pulse, please do not check both sides at the same time. That limits the blood flow to the brain. Systemic vascular resistance refers to how dilated or constricted the blood vessels are. So resistance of blood flow within blood vessels except pulmonary vessels. Right? Why is this important? Because this is a relationship between the size of the vessels and shock. Right? Remember that the patient in septic shock has widespread vasodilation. Okay. So we also have patients that are, vasoconstricting as well, like patients that are in anaphylactic shock. So there's a lot of things that you need to understand between them. We'll cover all those in the shock treatments. As far as the average adult, they have about 5 liters of blood, but children have about 2 to 3 liters. Infants, 300 mLs, about the size of a soda can or two. As far as normal circulation goes, perfusion is circulation of blood in the organ tissue, and we can measure perfusion status by measuring end-tidal CO2. The loss of normal blood pressure is an indication that the blood is no longer circulating efficiently, right? Look for the hypovolemic signs. The definition for shock is an adequate state of circulation involving the entire body. So an adequate state of tissue perfusion, right? Inadequate circulation